at women with multiple gestations. So these are 3 clinics, one at Parenyatwa Group of Hospitals and 2 at Salimu Gabe Central Hospitals. One of the clinics is manned by midwives who are seasoned in scanning multiple gestations. So they scan the ones that do not have any complications, they scan the newcomers, and then if they pick problems, they refer to the specialist clinic, which is manned by the specialist obstetricians and also the fetal medicine specialist. Okay, so what is important about multiple pregnancies? For us to give the specialized care that we talked about, what is special about these pregnancies is that we have to determine the gestational age properly, because the care, all the care is based on the gestational age. We have to establish the chronicity, because that's what is going to determine the complications that we should anticipate, the surveillance that we should give for that particular woman, and the fetal outcomes that we are going to have. Chronicity should be established as the first thing when managing a woman with multiple pregnancy, which is in the first trimester. We use the thickness of the intertwin membrane. We can also physically count the number of placental masses that are present. So the image on the right side there is showing a thick intertwin membrane, which is showing that it's a dichorionic pregnancy. This one is showing a thin intermembrane thickness, which is showing that it's a monochorionic pregnancy. So in the first trimester, these things are clearly visible. As the pregnancy progresses, it may be difficult to assess the intertwin membrane. That's why we are saying we should refer these women, or we should start to scan them in the first trimester so that we can assign the correct chronicity. However, if they present in the 3rd trimester, where it's difficult to assign chronicity, when we are not sure, we should assign the most difficult, the most severe chronicity. Like when we are not sure, is it a dichorionic or a monochorionic, we assign monochronicity, because that's where most of the complications are expected. And it means if we do that, the woman is going to get the care that is supposed to be given for a monochorionic pregnancy. But if you say it's a dichorionic when it's a mono, you are inviting challenges for that pregnancy. Okay. So the gestational age, we establish it in the first trimester using the crown rump length of the bigger twin. If they are presenting in the 2nd or 3rd trimester, we use the head circumference of the bigger twin. We don't assign different gestational ages to 2 babies who are coexisting in the same pregnancy. These babies were conceived on the same day, and most probably they are going to be delivered on the same day. So we don't say twin 1 EDD this, twin 2 EDD that. We use the CRL of the bigger twin, or the head circumference of the bigger twin. All the things that Mrs. Zanga discussed on pregnancy dating also apply to multiple gestations. So I'm not going to get into the details of that. Okay, so we said we are starting in the first trimester. And when they come, what should we do for them? We should confirm the type of gestation. By now, we all know that when we say multiple pregnancies, we are not just referring to twins. It could be a triplet, quadruplet, quintuplet pregnancy. So in the first trimester, we establish the type of gestation. We establish the number of babies that are viable. We establish the pregnancy location. We assign chronicity using the tools that I described in the previous slide. We label the fetuses using fetal position, fetal gender, placental location, or cord insertion position. The easiest labeling tool is fetal position. In our unit, we are using twin 1 for the fetus who is on the maternal right side. That is if the fetus is lying in a longitudinal fashion to the maternal long axis. If the fetal back is lying parallel to the back of the mother, longitudinally like that, and is on the right side, that one becomes twin 1. And if the other one is lying on the right side, also in the same fashion, that one becomes twin 2. If we have one baby who is crossing and is in the lower segment, and the other one is crossing and is in the upper segment, the one who's closest to the cervix becomes twin 1. The other one who is lying anyhow becomes twin 2. Things can be difficult, especially in the 3rd trimester. You can use fetal gender to your advantage if we have a boy and a girl. But if they are of the same gender, obviously you cannot do that. You can also use placental location, especially in a monochorionic, monoamniotic pregnancy. I'm sorry, you use placental location in a dichorionic pregnancy. And then for monochorionic, monoamniotic, that's when you use the cord insertion position if things are difficult. So in the 1st trimester, we also screen for everything that Dr. Chirume talked about, the trisomy 13, 18, and 21. We also look for major abnormalities like holoprosencephaly, having in mind that multiple gestations have a more common risk of congenital abnormalities. Okay, and we also just assess for the presence of adnexal masses. So after the 1st trimester scan, we are now sure how we are moving. We are sure of the type of pregnancy that we are having and the chorionicity as well. In twins, we can have monochorionic or dichorionic twins. They can also be conjoined, but for the purpose of this presentation, I will not get into the details of that. We can also have triplets, which may have 3 placental masses, 2 placental masses, or even 1 placental mass. We can have quadruplets, quintuplets, and all the higher order pregnancies that we can get. In our unit so far, the highest order that we've managed was a quintuplet pregnancy. Okay, so for twins, we said we can have monochorionic or dichorionic. Monochorionic, we are saying we have 1 placental mass and the babies are sharing 1 placental mass. They can have 2 different amniotic sacs or 1 amniotic sac. The one that have 1 placental mass, 1 amniotic sac, those ones are very rare. At any given point, if you are assigning that title, you really have to be sure of what you are doing because it's very rare. So I'm going to talk about the monochorionic, dichorionic. We follow them up from 16 weeks, 12 weeks, then the next visit should be at 16 weeks, at which point we start surveillance for the complications that we should anticipate in a monochorionic pregnancy. The most common complications are twin-to-twin transfusion syndrome. Our registrar is going to present on twin-to-twin transfusion syndrome. We can also have twin anemia polycythemia sequence, selective fetal growth restriction, single intrauterine fetal demise, preterm labor, and the TREP sequence, which is a rare occurrence. So, with these complications in mind, we see monochorionic pregnancies every week to actively look for these complications. So that's the reason why they are coming. If you are not able to screen for these complications, so it means you are not able to take care of a woman who's having twins. You have to refer. So when we see them, every 2 weeks, we are assessing fetal growth using the same biometric measurements that were mentioned by Mr. Zanga. We assess the biparietal diameter, the head circumference, the abdominal circumference, the femur length, and after we've done that, we obtain an estimated fetal weight for each baby. And then we calculate the discrepancy. The weight of the bigger baby, subtract the weight of the smaller baby, we get a difference. That difference divided by the weight of the bigger baby times 100. Then we get the percentage discrepancy. If that discrepancy is more than 25%, then it's significant. It's pointing towards something, either twin-to-twin transfusion syndrome or selective fetal growth restriction. We also assess the Doppler studies, umbilical artery, medial-cerebral artery, ductus venosus. The amount of amniotic fluid we assess using the single deepest pool. So if you are a sonographer, don't report amniotic fluid index in women with twins, because you are not able to divide the abdomen into 4 like what you can do with a singleton. So you report a single deepest pool for each baby. You subtract the smaller measurement from the larger measurement, then you have the discrepancy. If it's more than 6 centimeters, it's also significant, and it's pointing to twin-to-twin transfusion syndrome. Okay. We assess the fetal bladder volumes at every visit. You have to visualize the fetal bladder filling for both babies, and you flight the images on the same screen so that you can compare real time. If you assess this one, then go to that one, your assessment may be subjective. But if you do it real time, you'll be able to see if they are comparable or not. Okay. So we also measure the cervical length. Dr. Verenga emphasized that we have to screen actively for preterm labor. So this group of patients have an increased risk of preterm labor. So the ultrasound scan is not complete until we measure the cervical length and identify if the cervical length is shortening or not. So we continue to see them like that, and then at the 18 to 22 weeks anomaly scan, again we have to remember that they have a higher risk of congenital malformations. So our assessment should be more detailed because they have a higher risk. After that, we see them every 2 weeks. Monochorionic pregnancies should have a detailed ultrasound scan every 2 weeks. And then we aim to deliver at 36 to 37 weeks if we don't have any problems. If it's a monochorionic, monoamniotic, we aim to deliver at 32 to 34 weeks. Okay, so our registrar is going to explain a little bit more on twin-to-twin transfusion syndrome. I'm just going to take you through on how we manage and the things that we look for. So it can start as early as 16 weeks, between 16 and 25 weeks. It complicates about 10 to 15% of monochorionic pregnancies. It's a severe syndrome with a prognosis of 18% if it's not managed well. So, what is wrong when we end up having twin-to-twin transfusion syndrome? We have one placental mass. Can you see my pointer? No. Okay. Can you see it now? Okay, so we have one placental mass, two cords that have been setted anyhow, and they have blood vessels that are coursing throughout the placenta. In the end, we can have veins and arteries from twin 1 and twin 2. They may be close to each other. And it is known that if they are sharing one placenta, there is transfer of blood from one baby to the other. That is okay if the transfer is happening and it's balanced. But when we end up having a net transfer of blood from one baby to the other, it's like it happens. We end up having the one who is donating, they will have hypovolemia. The one who is receiving will have hypervolemia. So the one with hypovolemia will have less fluid around them, less amniotic fluid, a smaller bladder, and they will fail to thrive. The one who is receiving more blood will have more urine because they are getting more fluid, more amniotic fluid around them, and they can get into heart failure because of the fluid overload. I'm trying to simplify things so that everyone can understand. These things are easy. Medicine is easy. It's just as easy as I have just explained it. So, what happens when one baby is giving the other one fluid? On scan, what are we going to see? The one who is donating will have a smaller bladder. The one who is receiving will have a bigger bladder. The one who is donating can have no fluid or less fluid around them, oligohydramnios. The one who is receiving can have polyhydramnios. And we said this one can fail to thrive. And then they can end up having abnormal Doppler studies. We can have the one who is receiving fluid getting hydropic, and one of them can die. In most of the cases, it's the one who is receiving. Simple, isn't it? Very. So, I was going through the Quintero staging system for classifying twin-to-twin transfusion syndrome. The word is confusing, but what I have explained is what is represented by the Quintero staging system. Stage 1, we have just differences in the amniotic fluid volumes. Oligohydramnios, polyhydramnios. Stage 2, that's now when we have the differences in the bladder fillings. Small bladder, big bladder. Stage 3, abnormal Doppler studies in the umbilical arteries. Stage 4, that baby becomes swollen, fetal hydrops. Stage 5, we can have single fetal demise. Management. In our setting, we are not able to perform laser ablation, which is the management of choice. Because laser ablation is just going to ablate the anastomosis that is happening between the two babies right at the equator, and the problem will be solved. But in our setting, we are not able to do that. We rely more on conservative management if it's mild. If we are having polyhydramnios, loss of discomfort in one of the sex, we perform serial amnio reduction. That can relieve the signs and symptoms of polyhydramnios. We do that for stage 1, stage 2, when we are less than 26 weeks. When things are getting bad, we are more than 28 weeks, more than 30 weeks, we can plan for delivery. Okay, so the next important complication that we can have in monochorionic pregnancies is selective fetal growth restriction. In this one, we have one placental mass, as you can see in this image. At condensation, one of the babies inserts more centrally than the other one, who inserts at the little peripheral corner. Obviously, this one will have a more established vasculature that will occupy about 75% of the placental mass, meaning that they are getting about 75% of oxygen and nutrients. Well, this one will only remain with maybe 25% or less. This one will end up failing to thrive. When do we say there's selective fetal growth restriction? After we have assessed the estimated fetal, we have obtained our measurements, we have our estimated fetal weight, we do our subtractions, smaller from bigger weight, divided by bigger weight times 100. The percentage, if it's more than 25%, with no amniotic fluid discrepancies this time. Are we together? No fluid discrepancies. Then we say this is selective fetal growth restriction. We can also have one of the babies with an estimated fetal weight falling beneath the 10th centile. Just that is also diagnostic of selective fetal growth restriction. We can have one of the babies with an umbilical artery PI that is more than the 95th centile. That in itself is also diagnostic of selective fetal growth restriction. So we use those three criteria to pick selective fetal growth restriction in monochorionic pregnancies. Once we pick this, we follow them up every 2 weeks, assessing the estimated fetal weight and the Doppler studies. At this point, we'll be monitoring the deterioration of the fetal condition. Once we see that the baby's condition is deteriorating, we advise delivery. And then, if things are going on well, we can wait until 34 to 35 weeks, and then we advise delivery. What else can happen in a monochorionic pregnancy? One of the babies can die. For all the reasons that we have talked about, selective fetal growth restriction, twin-to-twin transfusion syndrome, TAPS, you name it, one of the babies can die. Once that happens, in a monochorionic pregnancy, we can end up losing both babies. But we don't order delivery immediately. We do objective assessment by way of using the Doppler studies and also a CTG. So we see them every week until they have stabilized, assessing the Doppler studies. Once they stabilize, we can start to see them every 2 weeks, assessing fetal growth and Doppler studies. And then the timing of delivery is at that point when we notice that the survivor is deteriorating. Or if we are able to push the pregnancy to 34 or 35 weeks, then we deliver at that point. So we don't say one of the babies has died, we are taking you to theater to remove one baby, and the other one will remain. We have seen women who were managed like that. So we are not going to be doing that. We are going to refer, we monitor, and then we deliver when it's indicated. Okay. Twin anemia polycythemia sequence is a younger brother of twin-to-twin transfusion syndrome. In this case, we have the same placental mass, the blood vessels that I flighted on the previous slide. But in this case, we have small arteriovenous anastomosis of chronic, slow movement of red blood cells from one baby who becomes the donor to the other baby who becomes the recipient. Because it's just red blood cells, slow and chronic, we are not going to have differences in the plasma volume. So we are not going to get the differences in the amniotic fluid volumes that I described earlier on. Rather, we are going to pick this condition on Doppler assessment of the middle cerebral artery. Mrs. Zanga described where we find the middle cerebral artery and how this assessment should be done. So in this case, we are looking at the middle cerebral artery peak systolic velocity. In simpler terms, we are assessing the speed at which blood is flowing across the middle cerebral artery in both babies. If the flow is slow, it means there is sluggish flow. Why? Because there is an overload of red blood cells. So the peak systolic velocity is going to be low in that baby who is the recipient in this case. In the other baby who is the donor, they are going to have less red blood cells in their blood, and blood will be moving at a faster rate. We are going to have a higher mean peak systolic velocity in the donor who may be having anemia already. So we are going to flight these measurements on the same graph, and we can see that this one is having a lower peak systolic velocity, that one is having a higher peak systolic velocity, and we diagnose TEPS. Okay, in the interest of time, I will move on to TREP sequence, a rare occurrence where we have one of the twins not having the torso or poorly developed torso, and this baby will be transfusing the other one. The most important finding on ultrasound scan is a mass in the baby. So if you see a mass in the baby, you have to refer, because in most of the times it will be a TREP sequence. Okay, in the interest of time, I'll move on to dichorionic twins. These ones, we see them in the first trimester. If everything is okay, we've done everything that is supposed to be done, we'll see them again at the 18 to 22 weeks fetal anomaly scan. And again, we'll perform a detailed ultrasound scan in view of the increased risk of congenital malformations. If everything is okay, we see them every 4 weeks now. We've moved from 2 weeks to 4 weeks. We will be assessing the fetal weight, Doppler studies, and the cervical length every 4 weeks. The timing of delivery is, if it's uncomplicated, is at 37 to 38 weeks, and we should not exceed 38 weeks. Common complications include selective fetal growth restriction, single intrauterine fetal demise. In this case, it may be due to selective fetal growth restriction, discordancy for congenital abnormalities. Those are the things that can cause single intrauterine fetal demise in a dichorionic pregnancy. They are also at a more increased risk of having preterm labor and preeclampsia because of the increased placental surface. Once we pick selective fetal growth restriction, we should see them every 2 weeks We have changed from 4 to 2 now, if there is selective fetal growth restriction, where we'll be checking the fetal growth and Doppler studies. If the fetal condition is deteriorating, we advise delivery. If everything is okay, we monitor until 34 to 35 weeks. If we have single intrauterine fetal demise in a dichorionic pregnancy, the outcomes are better compared to a monochorionic pregnancy. So these ones we also monitor every week until they've stabilized, and then we start to see them every 2 weeks and aim for delivery at 34 to 35 weeks. Okay, so for all the twins, the mode of delivery, in our units we are saying the safest mode of delivery for twins is cesarean section, a planned cesarean section, because we can have them presenting in all sorts of presentations. And we know that even if the leading is cephalic, there's need for manipulation for the delivery of the trailing twin. And this manipulation is no longer being trained properly in our units. And the experienced obstetrician who is needed for this delivery may not be present at that point. And we end up having one of the babies either dying or developing cerebral palsy. So we advise delivery by planned cesarean section. For triplet pregnancies and higher order, we start in the first trimester. We do everything that I mentioned. Every 2 weeks, we assess growth, Doppler studies, and the cervical length, we do it every month. We perform a detailed second trimester scan. The common complications, we can have selective fetal growth restriction, twin-to-twin transfusion syndrome, single intrauterine fetal demise, preterm labor, all the complications that we discussed earlier on. Timing of delivery for triplets is 32 to 34 weeks. For quadruplets is 30 to 32 weeks. That will be the end of my presentation. Thank you.
Thank you so much, Dr. Ndagurwa, for your presentation. So one fetus is already enough work, but nature decides to give us 2 or more. Imagine. So allow me to introduce the next speaker. So if you have any questions, keep them safe. We'll have a discussion session at the end. So allow me to introduce Dr. A. Mulema, who's a registrar doing OBS and GYN. She'll be presenting to us on twin-to-twin transfusion syndrome case. Let's give a round of applause.
Good morning, everyone. Thank you for the introductions. Yes, that's my name, Alice Mulema. So I'm going to present a case of twin-to-twin transfusion syndrome. And we decided to, so we are going to present a case of twin-to-twin transfusion syndrome, but what we should take note is all the complications that Dr. Ndagurwa was mentioning, they are not mutually exclusive. They can all happen at the same time. And this is one of the cases that you can see all the complications occurring at the same time. So she has already given us the definition of twin-to-twin transfusion, where we have got unidirectional placental vascular anastomosis. So one twin is the donor twin and the other one is the recipient. And this imbalance is going to cause cardiovascular strain, amniotic fluid discrepancies. And like we have already learned, it affects 10 to 15% of monochorionic diamniotic twins. In Zimbabwe, from the numbers in our fetal medicine unit, we have recorded an incidence of about 8%. This is lower than the global numbers because, like we have already learned, twin-to-twin transfusion syndrome has a mortality rate of up to 80% when it's not managed. So we do not tend to see these babies a lot because they demise before they are even referred. And I think this meeting and this case really falls in the theme of this meeting, which says strengthening standardized fetal medicine referral and management pathways. So if we refer them, if we strengthen these referral pathways, it means we have these twins managed earlier. So our cases of Mrs. VM, aged 21 years old, in her first pregnancy with no previous miscarriages. She was booked at 21 weeks. Like Dr. Werenga has said, most book later on after the first trimester. Her first trimester, according to her, was uneventful, but she started feeling this abdominal discomfort around 20 weeks. And it was worsening, associated with dyspnea. So she decided to book a pregnancy, and an ultrasound scan was ordered. Ultrasound scan showed a discrepancy in the amniotic fluid volume, and it also showed discrepancies in, so the first ultrasound showed that discrepancy in amniotic fluid, and she was referred to Salim Mugabe Hospital. At Salim Mugabe, in the multiples specialist clinic, she was seen, and the discrepancy of amniotic fluid was confirmed, as well as a discrepancy in the estimated fetal weight. Investigations were done, including an infection screen, oral glucose tolerance test, and the patient was normotensive, and there was no history of draining when we took the history. So at this point, with the findings of discrepancies in amniotic fluid volume, discrepancies in fetal weight, were differential diagnosis, TTTS, selective fetal growth restriction, which could also give that discrepancy in fetal weight, but it does not give the discrepancy in amniotic fluid. So this diagnosis did not really fall into place. This could be caused by upper GI abnormalities like duodenal atresia, and this way scanned for in both the twins, because when a twin is affected with the upper GI abnormalities, then they are going to have the polycythemia. But in this case, the recipient twin did not have these atresias. The donor twin could actually have renal abnormalities like renal agenesis and could give the picture of the oligohydramnios, but this was scanned for, and the twin did not have that. Another differential was STEPS, and we did the middle cerebral artery Dopplers, which I'm going to share. Another would be TREPS, but in this case, they were both viable twins. So I'm going to share the images, but the first images were really limited because the patient had excessive dyspnea and discomfort, but we managed to make the diagnosis and to rule out the abnormalities that I have spoken about. I would need help with the cursor. So for the first picture, which is on my right, it is showing oligohydramnios in the recipient twin, which was about 18.2 centimeters, thank you. Then the next diagram, it is showing the fetal bladder of the recipient twin. I do not have pictures of the amniotic fluid in the donor twin because the pool was not measurable and the bladder was not visualized. These were actively looked for because they've got a bearing on the staging of twin-to-twin transfusion syndrome. So Doppler studies, umbilical artery Dopplers were done for the recipient twin and for the donor twin, and they were both normal. middle cerebral artery Dopplers. So there was a discrepancy. For fetus A was the donor twin, there was a high PSV of about 59, and when we used the calculator to calculate the multiples of median, it was about 2.07. Then for the recipient twin, it was about 34. So this shows us that there was anemia in the donor twin and polycythemia in the recipient twin. And this table is showing the Quintero staging that Dr. Ndagura was talking about. And according to this staging system, our patient was stage 2, because we could not visualize the fetal bladder in the donor twin. We already had the oligohydramnios and the polyhydramnios, and we could not visualize the fetal bladder in the donor twin. But our umbilical Dopplers were normal. So this was stage 2. And then we planned for the management of this patient. Like she has already said, that the management that we are looking at, that will take care of the pathophysiology is the fetoscopic laser ablation, but we do not have it in the country at the moment, and work is being done to have it. So what we're going to do was conservative management. And for stage 1 of TTS, there is always a management dilemma, trying to balance expectant management and early intervention. So a study was done by the North American Fetal Therapy to compare expectant management, laser therapy, and serial amino reduction. And during this study noted that if we manage patients with TTS expectantly, 22% may actually regress, 8% may remain stable, but 60% can advance in stage, and 10% can have pre-viable preterm deliveries. So patients who had intervention had a lower risk of fetal loss in this study. Our patient was stage 2, and our management options, we have said we do not have the fetoscopic laser coagulation, so our options were amino reduction, septostomy, or selective feticide, but this can only be done in the pre-viable stage. So we considered amino reduction. Amino reduction helps to prolong the pregnancy, because you've got this woman, like I said, she was already dyspneic, and she had polyhydramnios, which could predispose to preterm labor. So when that amniotic fluid is reduced, you prolong the pregnancy and allow the babies to develop. Again, when we reduce the amniotic fluid, it means we are allowing this uteroplacental unit to be better perfused and be able to sustain the pregnancy or sustain these babies. So again, I'm going to share with you like this table, which was comparing serial amino reduction, septostomy, and fetoscopic laser coagulation. In terms of survival of one twin or survival of both twins, survival of one twin, when we compare what we are going to do for our patients, which is amino reduction and fetoscopic laser coagulation, survival of one twin is comparable for those management modalities. The difference comes really in neurological deficits. Dr. Ndagura told us about selective intrauterine fetal demise. So in TTTS, you can have selective intrauterine fetal demise, and when that happens, the survival twin will suffer neurological deficits. So when we use laser for coagulation or for management, we reduce the risk of neurological deficits. We're going to do amino reduction, which still carries a risk of 30% in the event that we lose one of the twins, which is one of the complications of amino reduction. And for septostomy, it means we are putting an incision between the membrane separating the twins to allow the fluid from the one with polyhydramnios to the one with oligohydramnios. It carries a risk of cord entrapment whilst the fluid is moving, and again, it also predisposes to preterm delivery. So this diagram is showing us the procedure which was done by our specialist on amino reduction. You can see the needle going in and removing the amniotic fluid. So our patient had two series of amino reduction. On the first one, she was admitted, counseling was done. This on this time, like she was going to have this procedure for the first time, so she had a series of counseling telling her that this may predispose to preterm labor. And again, the condition itself, she has to be told that she could actually lose her babies. So the amino reduction was done, and the patient was observed for preterm labor. Cervical length was measured, and it was reassuring. We reviewed our patients 19 days post this procedure, and clinically she had no abdominal discomfort, no dyspnea compared with the first time we saw her. From then on, we continued the weekly reviews, monitoring the Dopplers, and the fetal growth was monitored 2 weekly. Then a second procedure was done to reduce the amniotic fluid in the fetus. So this diagram is showing you, the first one is showing us the difference in amniotic fluid on day 19 post the first amino reduction. We can actually see that initially we did not have any measurable pool of amniotic fluid, but on this time, still there were membranes covering the baby. It was better from the stuck phenomenon which we saw initially, but then the decision was made to repeat this so that we can free the baby. The second picture is showing us after the second amino reduction. And in this picture, the baby were more free. The baby had more amniotic fluid around them, and this was reassuring that like growth was happening unlike the first time. Sorry. So this picture is just showing us, it's a graph showing us the estimated fetal weights of the baby. So the first time we saw them, there was a discrepancy. And the donor twin was about 600 grams and the other one was 1,000 grams. And like we have already learned about the charts, so our donor twin continues to grow, although right on the line, like on the 10th centile, whilst our recipient is growing at a higher rate than the one, but we'll continue to monitor them and also continue to monitor the middle cerebral artery Dopplers for the twin anemia polycythemia sequence. So in conclusion, I presented a case of twin-to-twin transfusion syndrome with selective fetal growth restriction in the donor twin and twin anemia polycythemia sequence, which was diagnosed at 20 weeks of gestation and managed by amino reduction. Maternal symptoms improved and the amniotic fluid discrepancies reduced. Although fetoscopic laser is the first line of management, amino reduction can help reduce the risk of preterm delivery and neurological deficits in the twins, and it is important to refer monochorionic diamniotic twins to specialist units on time. Thank you.
Thank you so much, Dr. Mlema. So as we ponder on a presentation, is sharing always caring? So let's ponder on that as we welcome the next presenter, who is Dr. Msara, Senior Reg in the Department Fetal Medicine Unit. Should be presenting on preeclampsia screening and prevention. Dr. Msara.
Good morning once again. Thank you, Mr. Kumbula, for the kind introduction. So I'm going to be presenting on preeclampsia screening and prevention. I've come across Dr. S. Ngwenya. He has published several studies on preeclampsia and eclampsia in Bulawayo and how it has affected and how it is one of the leading causes of maternal mortality. And in one of his recommendations, he actually recommended that there should be increased preeclampsia screening and monitoring and the introduction of simplified risk stratification tools. So as an introduction, preeclampsia is hypertension in pregnancy that is accompanied by significant proteinuria or organ damage and affects about 2 to 5% of the pregnancies in some regions, and in Africa around 8 to 12%. And I think that was the prevalence he also saw in his study. So it also causes severe maternal-fetal complications, contributing to around 76,000 maternal deaths and 500,000 infant deaths annually. And we can all agree that's a lot. Of note that medical therapy that we actually give our patients when we see them, because usually they present late, it cannot stop disease progression. Because most of our patients then tend to say, I'm now on treatment, do I need to come back? So it doesn't stop disease progression. The only definitive treatment is delivery of the placenta. So early onset often forces preterm delivery, which is one of the most common causes of neonatal mortality. And these babies also suffer from cerebral palsy. So hence the prevention, not treatment, of preeclampsia has been a major subject of investigation over the decades, and is still ongoing. So several prediction models have been put forward by the American ECOG, FSOG, FMF model. We also have ones from Australia and New Zealand, but several systemic meta-analyses have all agreed that the FMF model has better predictive value in terms of preeclampsia screening. So it takes into priority the maternal risk, which has been discussed before, the biophysical markers, and biochemical markers. So we're going to discuss one-on-one, and we all agree, usually in our public hospitals, we are doing the maternal risk. But the maternal history, at the same time, are we doing it properly? So I'm going to start with the maternal history. So we all agree we have different boards of obstetrics and gynecology which practice differently. So we should respect what they think. So if what you call binary scoring, I'm going to talk about the NICE guideline, which is most quoted in most hospitals, where when we see our patients in ANC, we just take a history. Do they have a previous history of preeclampsia? Like we all know, for example, if a patient has early onset preeclampsia in the previous pregnancy, we know the risk of recurrence is around 33 to 50%. We just tend to give them aspirin. And when we give our patients aspirin, we tend to cancel our patient that we have a 62% reduction of early onset preeclampsia. And then other patients like chronic renal disease, chronic hypertension, type 1, type 2 DM, autoimmune disease. But then it then goes on to say, you also need 2 moderate risk factors. If you see a patient with 2 moderate risk factors, you should give them aspirin. But I don't think we are doing this in most of our clinics. We just tend to concentrate on the high risk factors and give them aspirin. And then history alone has a detection rate of about 40% and a false positive of about 10%. So our FMF model, it combines the MAP, maternal factors, uterine artery pulsatility index. I think you were shown yesterday how to do that, and serum PAPE and PGF at 11 to 13 weeks. So this has been discussed before. And then the mean arterial pressure, how do we take it? So from the history, this is measured by the sisters most of the time. So it has been seen that MAP is more useful than just a single reading of systolic and diastolic pressure. So how do you calculate MAP? So 2/3 diastolic pressure plus 1/3 systolic pressure. And in pregnancies that have preeclampsia, we know that MAP is increased. So you let your patient rest for about 5 minutes. You take 2 sets of measurements at 1 minute interval, and then you put into your FMF calculator. But then you should be careful because there are other sources of error. For example, if you have incorrect patient positioning, cuff application and size, or if the patient of talking, it has been seen to actually increase the MAP by about 6, or a full bladder. So this is the measurement of the MAP. Your patient is sitting upright with the back straight, and your arm cuff should be placed at the arm level as your heart, and then you relax your hand or the patient is sitting comfortably on a chair, and then with your feet flat on the floor. So we should be careful about the cuff. I think we've seen most of the times that the cuff can actually affect the correct reading. So that was our map. And then we go on to uterine pulsatility index, which was demonstrated yesterday practically. So we see our patient, so what's the use of uterine artery Dopplers? So this has been explained before by Mr. Zanga, that is used in the examination of uterine artery in preeclampsia screening, and then it's high in pregnancies with impaired placentation, and it is associated with increased risk of developing preeclampsia. However, it has a detection rate of 26% for late onset preeclampsia and 48% in early onset preeclampsia. But the beauty of this thing is a simple, is a valuable evidence-based marker if it is in the correct hand and if it is done properly. So how do you perform the uterine artery pulsatility index? So you position your patient, and then you obtain a mid-sagittal section of the uterus and the cervix, as was demonstrated yesterday, and then you zoom your images and apply a color Doppler, and then you slide your transducer to view the paracervical region, and then you gently move the transducer from side to side to identify your uterine arteries. And then when you identify them at the level of the internal os, you then set your gate to 2 millimeters. This again was described in the morning. And then you set your angle of inclination about 30 degrees. So the peak systolic velocity should be more than 6 centimeters in the uterine artery. And then you obtain 3 similar consecutive waveforms. So you can do it transabdominally or transvaginal, depending on the gestation. So on the transvaginal approach, you're going to do it in an empty bladder. The patient is in the lithotrome position. Then you identify your uterine arteries at the level of the internal os. Remember your anatomy, the water under the bridge. It's about 2 centimeters from the internal os. And then you maintain your angle, less than 30 degrees, and then you record 3 waveforms. So the mean TVS tends to be slightly higher than the transabdominal, again because of the orientation and the anatomy of the uterine artery. So in the first trimester, which is between 11 and 13 weeks, you can use transabdominal or transvaginal, and the key reference about 2.35 for transabdominal and 3.1 for TV for transvaginal. And then the second trimester, transabdominal is actually preferred, and together again in the third trimester. And then we know that PI normally decreases with gestation. So a persistently high PI or notching actually implies poor placental remodeling. So this is just explanation again, as said in the morning, of the uterine pulsatility index. If it's less than 95th centile, it can be a normal finding. Then if it's high, then that's poor trophoblastic invasion. And early diastolic notch should be absent by 24 weeks. If it persists again, then you have high PE or FGR risk. And then if your PI is more than 9 centile, between 11 and 13 weeks, it detects 48% of early preeclampsia. And then you give your patient aspirin. So that was the uterine pulsatility index, which was demonstrated yesterday. So hopefully we're going to apply it in the next coming week. And then now we move on to biochemical markers, which continues to be a source of controversy in the low resource setting because of their prices. But the good thing nowadays, we are going to get rapid tests, which are available in other countries, around $20. So placental growth factor is synthesized by the placenta and is secreted by these trophoblastic cells. So it's part of the VEGF family, and we know it is potent angiogenic functions, and this one is cleaved by the S-fleet during the pathogenesis. So on its own, it has detection rate of 55% for early onset preeclampsia and a lower detection rate of 33% for late onset. And then our next marker is serum or S-fleet, which is an anti-angiogenic factor, which is again released due to hypoxia, due to abnormal placentation. So it's an anti-angiogenic factor, which is involved in the pathogenesis of preeclampsia and is elevated in affected pregnancies. So rising maternal serum S-fleet levels may actually precede the onset of preeclampsia by 5 weeks. So it means you can actually predict the coming of preeclampsia 5 weeks prior. So it has limited value in first trimester screening, as it does not significantly improve prediction beyond the maternal risk factors alone. So it's also being used as a ratio like S-fleet PGF ratio in other countries where they use a cutoff of 38. So if they see a patient of hypertension, instead of just managing as the same, they do this S-fleet PGF ratio. If it's high, then you increase your surveillance of the patient. So this is just a table to show again the detection rate of these markers at early onset and late onset. So maternal factors on their own, around 52%, and MAP, if we add MAP, increases to 72%. MAP plus uterine pulsatility index, 96%. So in low results, we can actually use the maternal factors, MAP, and uterine pulsatility index with a detection rate of 96%. This does not really require most of the patient's money. But then we can see we cannot really predict late onset preeclampsia. So if it's high risk, then you tend to monitor more between 24 to 31 weeks. Sometimes you may need to do Dopplers more often. If it's low risk, the patient don't need to come as much often as the high risk patients. So we see the second and third trimester screening is not for intervention. You are just going to use it for risk stratifying your patient. They need to come early. Sometimes you need to give them max sulfate, steroids, depending on the values. So what's high risk is, this has been described before, the prior risk that's put in a calculator. If a patient is risk of more than 1 in 100, using the FMF model, then you know your patient is high risk. And this constitutes about 10% of the patient. And you treat this patient with aspirin if they're still less than 16 weeks. If more than 16 weeks, you just improve the surveillance rate. You need to see them more often. This is again just the image showing the test that you offer the patient, the maternal factors MAP, uterine pulsatility index, PGF, and the high risk, more surveillance, right? We reassess them every 2 weeks or every week. Low risk, they just join the normal. So what does FIGO say? We tend to use FIGO or WHO guidelines in the low risk setting. So it also supports that all pregnant women should be screened for preterm preeclampsia at 11 to 13 plus 6 weeks gestation, use a combination of maternal risk factors and biomarkers, not maternal factors only. Where there is resource limitation, routine screening for preterm preeclampsia by maternal risk factors, MAP should be completed. But we are also adding the Dopplers because we are saying ultrasound scan should be available to everyone. And if they are high risk, then we give them aspirin. And if it's post first trimester, increase surveillance. So what are the gaps? What are the sources of controversy? So the cost. So I'll just say what Dr. Ndaguri says. You don't need to calculate the patient's pockets. Don't assume they don't have money. We have patients who actually ask for all these tests, even in government hospital. So we should offer these patients all the tests as an obs-and-gyn. Let them decide that it's expensive or not. Then what if these tests actually come down to around $20? We have to look at the cost versus cost effective. When these budgets are made, we look at cost effective. Because preeclampsia, for example, is costing around thousands and billions of dollars. Imagine if a patient is admitted in ICU. If you are admitted in ICU today with preeclampsia, you might actually pay $5,000 per patient. So why not just use this money to prevent preeclampsia, prevent maternal mortality, and prevent neonatal mortality? Then after 20 weeks, screening is more about early diagnosis and triaging. I know many obstetricians want to say, if she's past first trimester, why bother screening? Why should we continue screening? So we know we've seen patients, even in labor ward, labor ward, you just see them, they're eclamptic, but if you look at their book, their BPs were kind of normal. So if we had used S-split, we could have predicted 4 weeks earlier this predicament. And then we also have patients, we also have health workers saying, why not just distribute aspirin to everyone instead of them paying for all these things? So there is no strong evidence that universal aspirin for all pregnant women sufficiently improves outcomes or reduce screening costs enough to justify routine treatment. We know our patients can hardly take ranferon for anemia. Why add another pill burden to them? So what's my conclusion? So preeclampsia screening should be part of routine T1NC and should be continued throughout pregnancy. Accurate preeclampsia prediction plus prophylaxis reduces adverse fetal maternal outcomes, and using only history is ineffective. We should include MAP, we should include biochemical markers, and it will make a difference, even in resource-limited settings. Thank you.
Thank you, Dr. Sarah, for the good presentation. We move on to the next presenter, who is Misty Lyman Kumbula, who is a radiographer and is the CEO of MedPoint. Clap hands for Mr. Kumbula.
Thank you, Dr. Ndagurwa, for the presentation. So as the chairperson for this segment, am I immune to not having any questions asked after my presentations? The world is full of snakes, ranging from harmless grass snakes to burrowing puff adders. Ladies and gentlemen, my talk is not about snakes, but it's about the cervix. And we continue to preach or remind each other on individualized care, individualized screening. So I'll be talking about cervical length assessment, preterm birth screening, and prevention. So objectives of my talk, I'll briefly talk about preterm labor, the epidemiology, the prevention mechanisms, risk stratification, the protocols for preterm birth screening, as well as a few cases. So why does preterm birth matters? So as of 2020, about 13.4 million babies were born prematurely globally, and that contributed to about 1 in 10 live births occurring before 37 weeks. And prematurity is the leading cause of mortality in children under 5 years. I want you to think of the most recent premature baby that you managed and think about how it could have been avoided. So that's where this talk will be centered on, to say, of all these premature babies that are born in a limited resource like Zimbabwe, where intensive care unit facilities are scarce, what if there is a way of reducing those rates of preterm birth? So there are 4 things. We need to identify those that are at risk. We measure the cervix, act early, that will lead to improved outcomes. So by identifying the risks, we keep going back to the first presenter. We start off with the maternal history. So for those who've had a preterm delivery before, they had an already increased risk of having a preterm birth. But mind you, this should be individualized because they might have had a short or preterm delivery before, but pregnancies differ. So by identifying them, we have a preterm labor surveillance clinic at Salimugabe, where we see women between 11 and 13 weeks, and at that time we scan them. I'm going to talk about weeks, after which we then stratify them. So for those who would have a short cervix or with prior preterm deliveries, we then start to monitor them 2 weekly. For those with severely short cervixes, we then assign those to the preterm labor surveillance clinic, whom will be sending for sacrilege stitching session. Some will also be started on progesterone. So what is a short cervix? So the definition is that as per transvaginal measurement, a short cervix would be a cervix that is less than 25 millimeters. And those two images that you see on the screen are just showing one cervix is a long cervix, whilst the other one is a short one. So this is greater than 25 mils. Mind, as I'll be teaching students somewhere, we always rely on dimensions. So mind the image on the left, there's no dimension there to justify that it is a long cervix. So subjective assessment can also come with its shortfalls, hence the need to measure. So the one on the right, 15 millimeters, so that's a short cervix. So in some pregnancies, you might scan a patient, say at 20 weeks, you see a cervix like the one on the left. The reason why we then see them regularly, it's because what we don't see, you can measure the blood pressure preeclampsia, we can tell the maternal blood pressure is rising, but for the cervix, we will need to perform the transvaginal scan. So it will open internally, unannounced, and remember our goal is to reduce prematurity rates. So who's then at a high risk of preterm birth? So obstetric history, those who've had previous spontaneous preterm birth or mid-trimester loss. We know our women, they book late. So at the fetal medicine unit, regardless of the time they come to book, we then perform a transvaginal scan as baseline assessment of the state of the cervix. Then cervical history, this will comprise of those who might have cervical surgery, those with repeated dilatation, and those with uterine anomalies. So transvaginal will come in as the best modality compared to transabdominal assessment. Then current pregnancy also comes as a risk factor to say if it is a multiple pregnancy, there's also an increased risk of preterm delivery if there is associated bleeding in that current pregnancy. So allow me to take you back to this image. This color box over here also serves as a assessment to exclude a low-lying placenta and also the likes of vasa previa. So transvaginal assessment of the cervix comes as a multi-headed spear. You are not only assessing the cervix but also checking placenta or location, as well as excluding any vasa previa. Then social context, short interpregnancy interval, those who might have a very short pregnancy interval, they also score high on preterm birth delivery. Smoking, low BMI, maternal comorbidity, other illnesses that the mother might be having, and in our low resource setting, limited antenatal access. which is why we also decided to come to Bulawayo, so that there is Gwanda, there is Nkai, so you guys here can also go on and spread whatever you are learning, so that we also reduce any complications related to fetal medicine. So for the screening strategy, so if we see a patient between 11 and 13 weeks, and we measure the cervix transvaginally and it's greater than 35 millimeters, that is low risk. So that is for singletons. And for these ones, we then see them at the 20-week scan, the anomaly scan or mid-trimester scan. Then for those who will have a cervix less than 25 millimeters between 16 and 24 weeks, so this might also date back to the 11 to 13 week scan. So for some of them, we recommend a stitch, a cerclage stitch, and then we continuously monitor them fortnightly. Now, as for the protocol, so transvaginal assessment, we perform it on an empty bladder, so the patient is asked to empty their bladder, and we then seek consent, explain the procedure in full, that it's not a painful procedure. Infection control, we also try to make sure we are performing the scan in a environment that is clean, and also chaperone. So we also need to be mindful, even if you are female, always have a chaperone in your presence when you perform a transvaginal scan. Then the patient goes into the lithotomy position, and you gently insert the probe. I'm sure some of you might have had the privilege to perform a transvaginal scan yesterday. So upon gentle insertion of the probe, you achieve the mid-sagittal plane, and in that mid-sagittal plane, you should be able to see the internal os all the way to the external os. Then avoid pressure, so the anterior and posterior fornices must be of equal thicknesses, and magnify the image to occupy at least 75% of the screen. And then you measure from the internal os to the external os. And the examination time should be between 3 to 5 minutes. Reason being that if you perform it for less, you might measure the cervix. Perhaps there will be an ongoing contraction of the myometrium, which might falsely elongate the cervix. Hence, the 3 to 5 minute window. So that image at the bottom just corresponds to where you then measure from the internal os to the external os. So you would find that not all cervices are straight. Some of them also come, they present as curved. Hence, the need to trace from the internal os to the external os. Now, this slide is just showing what might occur, as I had indicated when I started my presentation. You know, we meet so many cervices and we worry about them shortening. So you'd find that for some patients, you might see them at 20 weeks, you see them at 24 weeks, and these cervices tend to also shorten without any predictable pattern. Hence, there is an algorithm that you can use, which is available at the Fetal Medicine Foundation website, where you take the maternal history as well as the cervix length that you'd have measured. As you then input it, it will give you a prediction to say this patient is at an increased risk of preterm delivery at 36 weeks or before 36 weeks, etc. So for those that have a cervix that is less than 20 millimeters, also prevent prematurity. So we've also had this evidence for the patients, the cohort of patients that we've been following up, to say those who do get progesterone and religiously use it, they also tend to go beyond 36, 37 weeks. So what are the common pitfalls when performing transvaginal assessment of the cervix? So during my training, it was common practice for people to measure the cervix on pregnant women, as well as using transabdominal approach. But transabdominal approach has its limitations, which can be disastrous. Number one, an overfull bladder can falsely elongate the cervix. Then what the bladder does, it will put pressure on the internal os as well as the external os, and then you might assume the cervix is closed. So of everything that I'm going to talk about, there's a video at the end. So please just focus more on that video. Whatever else I'm talking about, the video is the one that will summarize everything. So look forward to that one. So I was talking on the common pitfalls, and also avoid, when we are now performing the transvaginal scan, avoid too much pressure. So too much pressure can also falsely elongate or falsely shorten the cervix. Then wrong plane. So like I mentioned earlier, you need to measure at the level of the mid-sagittal plane, where you clearly see the internal os as well as the external os. And you might also meet funneling, where there is increased amniotic fluid pressure and the internal os tends to funnel. So you see images when I get to the few cases that I will present. So that image is a transvaginal assessment of the cervix, and you can see the thickness of this posterior fornix versus the anterior one. So this one, there was a lot of probe pressure, so you need to then retract the probe a bit so that the anterior and posterior fornices are of equal thicknesses. Then for those patients who would be indicated to get a sacrilege stitch, we then perform a transvaginal scan 2 weeks post-insertion to just check the position of the cervix, so of the stitch rather. So you would find that some of the stitches will be correctly placed and some might not be. So evidence now will impact the outcome. So the image on the left, these bright or echogenic structures, that's the stitch. This would be the internal os, external os. So what we'll be interested in is to measure the length of the cervix as I'm tracing, as well as the distance before the stitch and the distance post the stitch. So the image on the right is showing a stitch in position. However, the stitch is distally located. In some cases, the stitch might actually fail. So in some of these patients, we then recommend reinsertion. So this is a case of a 21-year-old para-O who had 2 previous second trimester miscarriages, and they had an indicated sacrilege stitch, which was inserted at 16 weeks, and they came for their anomaly scan at 21 weeks. So you can see there is evidence of these membranes bulging into the cervical canal, as well as the image on the right. So why it is important to also perform a post-stitch insertion transvaginal assessment to just check the position of the stitch. Then another case, a 33-year-old para-O, 2 first trimester pregnancy losses. A stitch was inserted at 16 weeks. And again, the stitch was distally located, hence the need for serial monitoring. Then for this one, 23-year-old, 2 second trimester miscarriages. Let's now focus on the images. So the first image, at 16 weeks, you would see the cervix was long enough, 25 millimeters borderline. Then the stitch in position, but with serial monitoring 2 weekly, you then find shortening of the cervix over time despite a stitch being in position. Then another case of a stitch failure. So you see the cervix is now open, and then that would be a failed stitch. Another image showing a stitch which also failed. So there is evidence of funneling, a short cervix. Then these are the knots of the stitch. One is in the amniotic cavity, whilst the other one is in the cervix. Hence, the need to monitor these stitches post-insertion. Then there are also success stories whereby the cervix was funneling, stitch was inserted at 21 weeks, monitored 2 weekly, then the patient went on to deliver at term. Okay, then this was a case at the anomaly scan, routine scan. Then there was evidence of bulging membranes. The cervix was already open. Hence, again, the need for routine anomaly scan. You also add the transvaginal assessment of the cervix, and our goal is to reduce the prematurity rate. So, image checklist. So, getting a perfect image also requires a standard, like the audit that was being mentioned earlier. So you can also actually get FMF certification if you send images to them of these cervical ultrasound images. So you need to make sure that the cervix is seen in the true mid-sagittal plane. You need to be able to identify the external os as well as the internal os. And you also need to ask, is the measurement technically valid? So remember, you need to measure over a course of 3 to 5 minutes, because there are dynamic changes that would also occur. So let's get to the last slide, the one that I said will summarize everything. So this was a patient. At first, you'd scan, the first minute you scan and you see a closed cervix. But over the course of 3 minutes, the cervix then started to show that there is actually short cervix with also funneling. One more time. Anyway, I'll share the slides. Right, there we go now. Okay, so conclusions and recommendations. Let's screen the women starting from the first trimester. The late bookers, at the time they present, let's also ensure that we perform transvaginal assessment of the cervix, as well as perform serial ultrasound assessments. Then we can also make use of the predictive models where we enter the cervix length at the time where we scan, so that we are able to predict risks accordingly. So here are the guidelines for performing the transvaginal ultrasound from ISOG 2022. And thank you.
Thank you, Mr. Kumpula, for that wonderful presentation. At this moment in time, I am the SADC chair, so I will be conducting the discussion session where if we have any question on the presentations which has been made from Dr. Ndagurwa, Dr. Alice Mulema, and Mr. Kumpula, I'm going to entertain questions. Can someone rove with the mic? There's a question there and a question at the back there. We are slightly behind time, so probably I would just take a few questions.
Thank you for those wonderful presentations. My name is Dr. Museta. I'm a gynecologist locally. I've got 4 points or questions to ask. The first one is that we are increasingly seeing young ladies having lip or LETs. These are treatments for pre-malignant lesions of the cervix. So a history of having had lip, is it an indication for suture just merely because when it heals the cervix is shorter? Second one, I would like to hear from Dr. Werenga if he could re-explain the significance of measuring the pre-stitch length and the post-stitch length, which he spoke about yesterday. He mentioned it in passing quickly, so I just wanted to find out more about that one. I didn't hear anybody from your department, obviously you know better than us, about the role of laparoscopic suture with a lady who's had a patient who's been having these recurrent miscarriages. Some people who don't have that skill of laparoscopy have been advocating open placement of a suture, laparotomy, before considering pregnancy. Then the last but not least is this issue of sexual intercourse after the stitch. Because a lot of ladies do come in having had a suture and they are complaining of the husband harassing them. Even though it's a high risk situation. So my question is, after lip, pre-stitch length, post-stitch length, laparotomy or laparoscopic suture, and sex after the stitch. Thank you.
Thank you. I heard some of the questions were directed to Dr. Werenga, but unfortunately he had moved out. Bear with me. I think the scope of some of the presentations which have been done were not covering part of the questions asked. So probably it would be unfair to hand the mic to Mr. Kumpula, but for interest sake, I think I will give him time to respond if you have any response. But I think most of the questions are out of the scope of his presentation.
Right, thank you so much. So let me start with the pre and post stitch. So from the presentation that I just did, there was an image. Perhaps I could just show it for ease of explanation. So for pre and post stitch, when the patient gets a stitch, we are more interested in the distance between the internal os to where the stitch knots are. So this will be the pre-stitch length, that will be the post-stitch length. So the closer these knots are to the internal os, we also call this one the cervical height. So the stitch knots that are closer to the internal os have been seen to have a better outcome compared to the distally located ones. So the shorter the cervical height, the better the outcome. I hope I've responded to the first one. Then the other one on the abdominal stitch, yes, evidence has suggested that that one is more secure, though the stitch would need to be removed at around 36 weeks. So in case the patient gets into spontaneous labor, then it becomes an emergency.
Thank you, Mr. Kumpula. Yes, on the laparotomy one, especially for those patients who have had repeated pregnancy losses after the transvaginal one, you can then try the one which you put a laparotomy. Dr. Werenga is back. I think I have told him some of the questions.
Thank you so much. Thank you. So the pre-stitch length, the reason why we assess it, because we assess it to check for cervical stitch failure. In about 10 to 14% of the pregnancies, we have a stitch inserted, the stitch fell. How do we know it has failed? I think Mr. Kumbula explained well that the moment you have the membranes bulging up to the level of the stitch has failed. Why do we say it has failed? Because what the stitch should do, it should give us a functional length in front of it. The stitch shouldn't hold the cervix mechanically. Why? Because the cervix is soft tissue, it will be torn if the uterus continues to cramp. Besides, the membranes will start rubbing on the stitch sometimes. I don't know how, but it starts rubbing on the stitch, and that causes membrane rupture. So that's why we measure the pre-stitch. The post-stitch length is not very important here. Well, we were excited to see it, but in terms of the effectiveness of the stitch, the pre-stitch length is one that is telling us the story, whether our intervention is working or not. I think Sten already answered the role of laparoscopy to say for women who are constantly failing the stitch, because indeed we have those kind of women, laparoscopic stitch has been proven to be more effective in those cases. Then sexual intercourse, for women who have a stitch outside rescue sacrilege. You know, rescue sacrilege are those women with bulging membranes that have already gone past the external os in most cases. We normally do not forbid women from indulging in sexual intercourse after a stitch. But for women who have rescue sacrilege, you sometimes ask them to wait until we reassess them after a week, because we normally bring them after a week to reassess if the rescue sacrilege is working. Well, the rescue sacrilege again fails, but in some women it works. Yeah, so I think.
Okay, I think the other question which I forgot was about women who has lip and universal sacrilege.
As far as lip is concerned, the evidence points that only women who have got two lips are at increased risk of preterm birth. If it is one lip, what we do is we bring them for cervical length assessment. If the cervical length assessment passes at the 20-week anomaly scan, we reassure them. But women with two lips, we do not necessarily recommend cervical stitch insertion, but we put them under preterm surveillance. At 20 weeks, we check the cervix. If the cervix is more than 25 millimeters, then they come every 2 weeks to the preterm surveillance to check whether their cervix is going to shorten quicker or not. Let's always remember that women who have preterm birth, if we measure their cervix at 11 to 13 weeks, they will probably have a normal cervix, but it is the rapidity of the shortening that differentiates these women. Those who have preterm birth, the cervix shorten quicker. Those who don't have preterm birth, their cervix shorten slower, because all cervixes shorten towards term. But the ones who don't have preterm birth shorten slower, so that they get to term with a cervix which is probably between 2.5 to 3 millimeters, or even above 15. Because the cervix above 15 millimeters, above 34, 36 weeks, doesn't necessarily predict preterm birth.
Thank you, Dr. Verenga. I had said because of time I'm going to limit the discussion, but I think there was a second question. You can give the mic so that we move to the next segment.
Thank you so much. I'm Dr. Tewafire, currently stationed at UBH. I have two questions, one for Dr. Alice. Thank you so much for that case presentation. My question is, in that patient, you said you did amnio reduction. Is there like a cutoff point where we say we are going to remove this much amount of amniotic fluid, or it's just subjective? That's the first question. And then the second one is directed to Dr. Msara. On a prediction of preeclampsia, you mentioned about the mean arterial pressure. What's the cutoff point again as junior registrars, we need to know because these questions will come to us.
Thank you, Doc. For your first question, I'm not sure whether to end to Dr. Alice or to Dr. Ndagurwa, but I will start with Dr. Alice. Then, if she has some issues, she will hand over to Dr. Ndagurwa.
Thank you for the question. So, in amino reduction, when we are like doing the procedure for the patient, there is really no limit to say there is a cut-off, but we are also considering the maternal symptoms. Like in this case, when our patient came, she was dyspneic, and we are also consider about the risk of preterm labor in this patient. So we take out as much as we can, but we are also we will consider also hypovolemia in this patient, for she'll be in supine position for a long time, and again we are going to monitor her for preterm delivery or preterm labor. So we will keep her in hospital, give her tocolytics to just manage for that. But in terms of a cutoff point for the volume, there is no volume. Thank you.
Thank you very much for the question. I think like what I've explained when I was talking about the FMF model, I said you put in your map, you put in your uterine fertility index. It's a priori risk. There's no strict cutoff because it's a continuous variable according to gestational age. Of course, some papers will quote around 85 to be abnormal, some will quote around 90, but it's a continuous variable that you actually put in your calculation.
All right, thank you, Dr. Msara. So as you see, I'm very short, and my chairmanship is also short and precise. Over to you.
Thank you so much. Oh, sorry. Right, so as we continue with the next segment, allow me to invite Dr. Verenga one more time. So Dr. Verenga is going to introduce us to fetal anomalies. So can we put our hands together for Dr. Verenga?
I didn't realize my time had come. Thank you. Okay. Thank you. Good afternoon. It's afternoon, right? Yeah, it is. Good afternoon. So we want to continue from where we left in the morning. But this time around, we want to talk about fetal defects. This is the roadmap I want to take you through. I want to make sure I finish before it is one, right? Or just after one, so that people don't blame me for a late lunch. So I'll share with you the burden in terms of the local cohort, what we have done in our work, and also the organ systems that we come across more often. Then I want to talk about detection of fetal defects, both first, second, and third trimester. And I also want to talk about investigations, screening versus diagnostic tests, and also the counseling and the care pathways that the patients go through whenever there is a defect. Whenever we make diagnosis, the diagnosis must lead to prognosis, counseling, documentation, and a pregnancy care pathway. When we started fetal medicine, I used to have problems with my colleagues. They would actually say, I just wanted you to scan. Why are you telling me how I should manage the pregnancy now? Then I'd say, no, that is my job. I have to tell you how the pregnancy is managed because there's a problem that is in my domain where we have to discuss the care pathway. Say, how should a pregnancy with this defect be managed for a better outcome? But we are happy that now people do understand this, that it's a domain that requires a lot of time, and also that requires investment in time that normally, if somebody is practicing obs and gyne, you won't have the time to invest enough to be able to be confident to talk about how this pregnancy is managed. So that is our job, to make sure we take away that burden. The question is, why fetal defects matter? They matter because they contribute to under 5 mortality, and this substantial burden is in low to medium income countries. I've just shown you some figures from WHO here. What you will notice that as the other conditions of death have improved in other countries, one of the standout things that you notice that there has been a rise in the fetal defects or congenital anomalies as the cause of why babies do not make it. Let me get a point out. That way I can. So we can see that there is a rise in the contribution of congenital anomalies. They contribute up to what? Up to 30% in these graphs here. So it's a big burden we have, and unfortunately in Africa, most babies are underdiagnosed or undiagnosed, and these defects are actually hidden. If a baby has, let's say, probably bilateral hydrothorax and is in Chicombedzi where probably no scan has been done, this baby already has some hypoplasia of some sort, pulmonary hypoplasia. When this baby is born and demises in the early hours of birth, the cause of death is going to be recorded as unknown. This is why you see, if you look at the pie chart of our national mortality, the unknown cause of neonatal mortality contributes something like close to 20%. But in obstetrics, we know that what you don't know, you can't find solutions to. You can't solve what you don't know. So if 20% of our babies are dying and we don't know why they are dying, that's catastrophic, right? So this is where we are coming through to say anomaly scans should be done the way they are supposed to be done, so that we can make a dent into this 20% of the unknown cause of why babies do not make it. Just to show you our own cohorts, to just convince you that indeed fetal defects okay, and they are real, and they are amongst our people. So you can see from the 9,513 pregnancies scanned, we have now scanned more than 30,000 pregnancies, but I'm just showing the data of 9,513 pregnancies here, where we had 176 fetuses with defects. And the total number of defects was 340, which was an incidence of 2 in 100. And I think this 2 in 100 is what is commonly caught in most publications whenever defects are mentioned. Out of this cohort, this is the distribution in terms of the systems. So from this cohort, we noted that central nervous cardiovascular system was leading in terms of the defects, and as you can see, I think there's been a mix-up of figures, but central nervous system was number 2 in our cohort of defects. So the defects actually do exist, and they occur everywhere where pregnant women are. If you are working at a center that probably delivers 2,000 women a year, just know that on average in your center you should expect probably to see something like what, 200 defects in that center. If you are not seeing them, then they are being missed. That is what it means. So to just show you again the other systems, these are the pulmonary hypoplasias, the VSDs, tracheoesophageal fistula, AVSD, aortic stenosis, Arnold Chiari, ventriculomegaly, acranias. Everything that they taught you in embryology does exist. That is all I want to put across. Because sometimes when you read books and you don't experience what you read, you think books speak of things that do not exist amongst your people. But they actually do exist, all these defects, and they are there to be picked. So to show you the other system, that the defects occur in almost every other system that you can imagine, including the very rare abnormalities that you read in textbooks. We've come across them in our line of work. So what is the approach across pregnancy when it comes to screening for fetal defects? First of all pregnancies ideally should be optimized. In other words, whenever a woman decides that I want to fall pregnant, The ideal thing is that a woman should go and see a doctor, preferably an obstetrician, and talk about their plans to say, look, I want to get pregnant. Women may have risks that they don't even recognize that they have, even if it's their first pregnancy. So pre-pregnancy evaluation is standard that every woman should have it. Women may be on drugs that they don't know that is not good for their babies, and they may go on and fall pregnant, and this may result in fetal defects. Most women's diet is already deficient in folic acid. Why? Because we all boil the vegetables until they change color. The moment we do that, we're burning away the folic acid, and probably we eat the wrong fruits which do not have enough folic acid. So all these are the reasons why women should go for preconception evaluation. So after this preconception evaluation, the journey of screening for defects on the baby itself will start at the 11 to 13 week scan. Yesterday we had the opportunity to demonstrate how we do it. How do we screen for acrania? How do we screen for anencephaly? How do we screen for hypoplastic left hearts? And how do we screen for myelomeningocele at the 11 to 13 weeks? Then after the 11 to 13 weeks, they again come back at the 18 to 24 weeks and they get a screen. Then they come again at the 36 weeks and get another screen. That is the pathway for screening for defects. I know the teaching has been the anomaly scan. The anomaly scan, as if that's the one silver bullet that is supposed to screen for all defects. But I want to prove to you that is not correct. Let's look at Agiro Singelak's work. When Agiro Singelak looked at the database of 100-something thousand women that were being scanned at the fetal medicine units at King's College, she noted that in first trimester there was a detection of 27.6% of defects in the first trimester. And which were the defects that were being detected in first trimester? If you look here, these are the highly detectable defects: the acrania, the allobaholopros the encephaloceles, the exomphalos, the gastroschisis. So these are first trimester diagnoses that everyone who is coming according to protocol should be able to detect. So picking up gastroschisis at 20 weeks, holoprosencephalus at 20 weeks is too late. It's already late. They should be picked up at 11 to 13 weeks. Then the other ones that can be detected with the moderate detection ability: open spina bifida, these are the myelomeningocele. Yesterday we were demonstrating the BSOB ratio, the brain stem hospital bone ratio, where we were saying it's a screening tool to screen for myelomeningocele. Then the hypoplastic left heart, the AVSDs, the complex congenital heart defects, and the lower urinary tract obstructions. These can be picked with moderate detection ability. Then the ones we know, they will not be able to be picked up with certainty, or they are likely to be missing the first trimester. Conditions such as ventriculomegaly, agenesis of the corpus callosum because it develops later, the CPAMs, the cystic pulmonary adenomatous malformations, the renal anomalies, and the talipes. We know we may not be able to pick up this. Hence, the 12-week scan, while it picks up the other defects, it may miss some. This is why they have to be brought again at the 20-week anomaly scan. So again, if we continue with Agiro Singelak's work, we see that the detection ability, this is the overall. I'm not talking about system. There are some systems where the detection is very high for certain defects. The overall detection of all the composite anomalies was about 53.8%. And which ones were more likely to be picked? We can see the VSD, AVSDs, the outflow tracts of the heart, the ventriculomegaly, the agenesis of the corpus callosum, the neural tube defects, the hydronephrosis, the multicystic kidneys, the cleft lip palate, dysplasias, and the skeletal dysplasias, limb and posture defects, the bowel obstruction, abdominal cysts. And why is the yield almost 2 times? It's because the organs are larger, planes are clearer, the bones are less ossified, so the views are better, and the defects themselves are evolving in a way that allow people to see them. Right, let's go to third trimester. In the private sector, we no longer bring them at the 36 weeks. We still do it in the public sector because we fear the burden it will give us. But in the private sector, we now bring them at 32 weeks because we have learned something over the years. When you reflected on our work, that there are some babies. You do not tell people at 36 weeks that there's something wrong. When you pick it up, most of the private sector, the bar is very high, right? So, what was detected? 2.1% of the defects were detected for the very first time in the third trimester. The question now is, why? Because certain defects do not evolve before third trimester. I'll give you examples. Even babies with achondrogenesis, you know, the ones you call the dwarfs. Yeah, at 20 weeks, those bones will be just borderline. In the hands of most people, they are normal bones. But they begin to shorten after 25 weeks. So in a normal scan may pass a baby with achondroplasia. So that if they don't have any other scan, when they come at the 36-week scan, that's when people discover that there's achondroplasia. Other defects like ovarian cysts, babies who have ovarian cysts, girls, they have ovarian cysts. They will not have it at the 20th week because the hormones won't be playing a very big role then. So you may bump onto an ovarian cyst. Microcephaly, it's a third trimester diagnosis. So we still need an anomaly scan in the third trimester. Vein of Gallen malformations. It's a very terrible condition with very high mortality in our hands, or not in our hands, but in our country. It's 100% mortality for all the babies, whether both public or private. They've all died, the ones who have diagnosed. But it's a third trimester diagnosis. In the second trimester, there's nothing. You will see there. But in third trimester, then you begin to see that there are some cystic structures in the baby's brain, and when you put on the color, you see all these malformed veins in the brain, right? Mild ventriculomegaly, again, you miss it in second trimester because it will be normal. It will manifest later the duplex kidneys, the hydronephrosis, and some of the VSDs. So these are late findings. So that means when women come in third trimester, they also need an normal assessment because of what we are learning from this week. So what does it mean? It therefore means that the first trimester will allow us to pick severe early defects, because it's not right to tell a woman that you have got anencephaly at 20 weeks when it can be done at 12 weeks. Because my clinical psychologist colleagues will tell you the mental effects of telling these women that everything is not okay when they have already done the preparation, they've colored the rooms, they've gone to Dubai to buy nice things, and you told them that your baby is not going to make it in third trimester and there's no brain. It's unimaginable, right? So this is why we are talking of first trimester. Once you have done the first trimester, we also do risk stratification. This is where women also volunteer to us, say, Chiremba, I've been taking losartan. I'm hypertensive, right? Yeah, which is a very common drug which physicians love so much, but we know it poisons the baby's kidneys. So these are the women then who say, I will flag you and I want to monitor your kidneys as you stop the losartan and see if they will recover or if they will continue opening up, right? Then the second trimester is the most high yield scan and they have to have it. Then the third trimester is there to check for the late evoluting conditions and some occult defects. So in other words, there is no single scan that detects all fetal abnormalities. A staged trimester-based strategy gives the greatest diagnostic value and will increase our detection rate. So what am I trying to do? All I'm trying to do is I want to dismantle the old system whereby people will pick one scan and say the anomaly scan at 20 weeks is the only scan that a woman should have. And I also want to dismantle the notion that women need one or two scans, because you will find it when you read the literature or when you read some national documents that people talk of one scan. But I want to dismantle that, because I think women should be given the best standard of care
available. So once we have done the anomaly and we have picked up this anomaly, the next thing is, what is the screening strategy and the diagnostic strategy? Normally, we highly recommend, especially in the private sector, which I want to encourage everyone here, that in the private sector, offer the clients you see they're the best. Don't offer them suboptimal. So what is the best we offer? We offer them NIPT to say, look, we know that babies with Downs, 20% of them will hide us from us on scan alone. Because only 80% of babies with Downs will show you something suggestive on scan. The 20% won't. So we told them the 20% will hide from us. So as a result, we can't guarantee you that your baby is not in the 20%. The only way for us to be sure that your baby is not in the 20% is for us to do fetal cell-free DNA test. Because the fetal cell-free DNA test, the NIPT, will allow us to pick these 20 that we couldn't even suspect on scan. So we offer them the fetal cell-free DNA test at 10 weeks. So when they come to us at 12 weeks for this scan, we are already assured that this baby is not in the 20%. So that when we tell them that, look, we've checked your baby and the findings are reassuring, we have this layer of coverage, you don't have this mango on our back. Because if you don't do it, you always have a mango on your back. You're saying, what about if this baby is on the 20%, and when the baby comes out, you know how it works, that if the baby is born with Downs, the first thing is, we went to fetal clinic, Dr. Everenga scanned us, but our baby was born with Downs. Right? This is how the stories are formulated. But for a layer of security, we have to declare this. So look, 20% will miss if we don't do fetal cell-free DNA test. And believe you me, women are doing this test. However, it doesn't exclude copy number variants, the single gene disorders. So when you do the scan, the next thing, whenever we have a defect, we want to know, why do we have it? I'll show you on the next slide the association of defects and chromosome abnormalities, but we have to subject the woman to these diagnostic tests. I'll explain them later. And then they also have to be cancelled by the counseling team who give the additional counseling. This is the genetic contribution to malformed fetuses. Because some people may wonder and say, you have already diagnosed the defect. Why are you bothering these women by doing further tests? We are doing these tests because we know that 25% of babies' defects will have chromosome abnormalities. Then the other 8% will have sub-microscopic copy number variants. What do we mean? What we are saying is, when you do karyotype, conventional karyotype, and you say there's a translocation or there's a duplication translocation, it's because a large chunk of the chromosomes is duplicated or translocated. But if there's a small portion of it which is translocated or duplicated or deleted, you are not going to see it using conventional karyotype. It will be missed by the laboratory. But we know that these small duplication deletions are associated with the defects. So this is where the issue of chromosome microarray comes in. So chromosome microarray is zooming in further than what a conventional karyotype do. I know most people were taught on conventional karyotype, but it is now well known that the conventional karyotype is not the best answer to babies with defects. Because a substantial of them, 75% of them, will come with a normal karyotype. But that does not mean the gene is normal. It's just that we have used a superficial test that is not looking deep enough. Right? Let's unravel this. Then the other 10% will have single gene disorders. The question now is, what do we do with the single gene disorders? This is where we are now doing the whole exome sequencing. Let me jump this, right? Let's go to this, because I'm talking about whole exome sequencing. So this is where we do the whole exome sequencing. What are we doing with the whole exome sequencing? With the whole exome sequencing, if we do not know, if there's no family history that tells us that probably there's a history of hemophilia and we want to screen for hemophilia, or there's a history of this condition, then the laboratory cannot do any directed testing, cannot do this single gene targeted testing. So this is where the whole exome sequencing. What is the whole exome sequencing? We were taught, is it physiology, that only 2% of our gene codes for protein or makes us who we are. Only 2%. So now, the sequence of the nucleotides are the thymine, guanine, adenine, thymine, cytosine. That arrangement of the nucleotides was studied when the whole genome sequencing project was done almost 15 years ago, right? Around 2012, that's when it was completed, right? So it is now known how the human genome nucleotides are arranged on the chromosomes. So this test we are saying whole exome sequencing is going out there to check if the baby's arrangement of these nucleotides, these building blocks, is conforms to what a normal human being should look like. So this is the level of testing we are carrying out. We should be given to women because people need answers out there. People need answers. It's not good enough to tell women that your baby is a defect and they'll tell you what has caused it. You told them, I don't know. It's not good enough. People need answers. So why is my baby not normal? So this is the level of testing that we have to do. But let's also remember that it is now known that the other 98%, which we were thinking is redundant genome, can actually cause disorders because these are control, promoting proteins, structural supports. If they are abnormal, they can also cause a variation in the phenotype. So this is where the whole genome sequencing comes in, where the whole nucleotide arrangement is going to be studied. And these tests are already happening in Zimbabwe. There is a rare disease clinic run by our pediatric colleagues at the university, where they are offering whole genome sequencing to babies with abnormal phenotypes or genetic syndromes when they are born. It's run by Dr. Kandawashika, this clinic. So they are running whole genome sequencing on babies we do not understand to say, oh, how is this baby? They are doing that. So these are already happening. So this is what babies with defects will go through to try and understand what's going on. These tests are run. And we are doing them in Zimbabwe. Because people will think, they don't understand, they don't exist. They do exist. Once we have defects, we categorize them to say, is this a minor, is this a major, lethal or non-lethal? I've just put them in category to show you sort of groups. These are not all the defects. There are more than 200 defects we can pick on babies. But to just show you the common ones, say when you see this defect, where does it sort of fall into? So you will see that these ones are lethal. The anencephaly, the alloboloplesencephaly, probably close to semilobar, but semilobar causes severe mental handicap, severe pulmonary hypoplasia, body stroke anomaly, bilateral renal genesis. These defects are lethal. When you are saying lethal, means they are not compatible with life. Whether you go to Tokyo, Japan, or to Sydney, Australia, these babies, there's nothing that can be done for them. So that when a report comes and tells you that there's alloboloplesencephaly, don't offer alternative message, because sometimes babies are diagnosed, then the obstetrician say, don't worry, maybe things will change, let's keep on, and then you end up doing a seizure, right? Yes, these things do happen. Or severe pulmonary hypoplasia, the mother is falsely reassured and then ends up getting a seizure. But we need to know that these are lethal conditions. There's nothing that can be done to salvage the baby's life. These ones will cause major defects. It will now depend on the interpretation of the risk and the preparedness of the couple to look after a baby with defects. So this is sort of the management algorithm that we normally follow. So whenever we detect a defect, we want to know is it minor or major. If it is minor and there is no surgery required, then it's just routine, and the timing of the delivery sometimes depends on the obstetric reason for minor conditions. Then if we think it's a surgical condition, then we have an MDT where we gather all the necessary people. If it is an ortho condition, we gather the ortho in an MDT, we discuss everything, including, is this something that you guys can fix? And if you fix, what is the outcome of these babies? so that we go back to the mother and give them informed counseling about the condition so that they can make an informed decision. Then we also discuss the issue of termination to say, should we offer termination as a viable option or not? Then out of that MDT agreement, we go back to the parents and tell them what the MDT will have decided. If it is not a surgical condition but needs the other specialties, the renal people, the renal pediatricians, you call them. The neonatal are part of the MDT permanent members because they receive these babies anyway. Then of course, if there is need for diagnostic testing, we do diagnostic testing because the association of chromosome abnormalities is a bearing on the outcome. Then the MDT that they are given, they are cancelled by the clinical psychologists, not once but several times, before they can commit to any decision, pregnancy defining decision. Then for major defects, we always want to confirm the liver phenotype, confirm the diagnosis, genetics, the recurrence risk, counseling, and also for the non-lethal, it's almost the same way here, but in this case, we'll be talking about treatment, bed then, the neonatal plan pathway. This is all done under the MDT now. We now have a well-established multidisciplinary team meeting that discusses these cases, where we discuss together. Where prognosis is poor or treatment is not pursued, that's where we introduce supportive care versus termination of pregnancy. The termination of pregnancy we are discussing, we don't prescribe it. We offer it as an option, and the couple, after counseling with the counseling team, they will make their informed decision whether they want to keep or they want to terminate. Then the delivery planning, again, depends on the condition, and also the discussion of the MDT, and also our advice as fetal medicine experts to say when should these babies come out if everything is stable. Then the termination pathway, it's a legal pathway which we follow. I should just show you some of the pathway, but we try to do non-directive counseling, and our team, counseling team, always reinforces this when they talk to them. Of course, there's documentation that takes place everywhere. So these are the counseling essentials that we follow through there. We sometimes have to repeat the scan because they may request that we see them again. Then we discuss. Then we also explain the issues of the survivability, the disability, and the uncertainty. Because there are certain conditions that are very uncertain, where you don't know what is really going to happen to these babies. Then, of course, the genetics, the MDT input, including the counseling sessions, then the delivery and the newborn. And let me emphasize that our MDT extends to the delivery period, because we also discuss the outcomes. The reason why we are doing this is we are so building the MDT to the capacity, to a level capacity, kind of. What I mean is, fetal medicine is still a young field in our country, and the experience of prenatal diagnosis and linking them to the true outcomes. What I mean by true outcomes is, yes, books may tell us that gastroschisis survived by 80%, but in Mupilo Hospital, what is the survival? Because this is the level of counseling we want. This is the level of MDT discourse we want to say, yes, books tell us that gastroschisis have a good outcome. But when a baby is born at Mpilo after prenatal diagnosis, do they have an 8 to 10% chance of going home? This is where we want to zero it up to in terms of the level of our other colleagues, the pediatric. We know these outcomes, we've been following them for years, that they are not good, but our surgical colleagues won't be having their true outcomes of the prenatal diagnosis. So they'll probably be having these very high figures of selected cases. So they will tell you they do very well, they do very well. So we say, okay, let's follow the outcome and present them. Then we know after 2 years, we'll all be thinking the same kind of, right? Because we'll be sharing the true outcomes of what is going on with our patients. Right, so to just round up, so this is the procedure we offer to, because people may wonder, if you see these defects, the termination, how does it happen? We offer feticide. I'd attached a video there, but I've decided I will never share this video again after people said I traumatized them in one of the presentation. So I just wanted to know that what we do is we unfortunately have to do this, we introduce KCL into the baby's heart under ultrasound scan guidance. We put our needle there, and we stop the heart using KCL or oliginoken, depending. It's a traumatic procedure, I think, for everyone, including the registrars. They don't know it now because they've been enjoying the procedures, but I think later on will also be affected in a way, because it's not a nice procedure to do, but we have to do it because it's part of our work. But that is what we do. Because people may wonder, say, you are diagnosing for what? We're diagnosing so that those who choose termination, they can also terminate, because it's also a lean therapy for some couples. Right, so this is the algorithm. Systemic scanning with saving of the images, because sometimes you may want to look at them. Then we define lesions, look for association, choose the right genetic test, counseling, prognosis options, MDT pathway, then the birth of the baby under the MDT cover, then the newborn care for those who keep or the defects that need corrective surgery. Some patients, we transfer them in utero to centers that offer the surgery, the ones we diagnose in utero. Then, of course, the outcome capture and the risk of recurrence, we always discuss it. Thank you.
Right, thank you, Dr. Weringa, for that presentation on fetal defects. So we were supposed to have other two presenters, but we'll take a short break for lunch, then we'll resume the sessions soon after. So if we can all be back by 2 p.m., then we have the two other presenters. Yes, Doc.
Sorry, am I allowed to ask now? Or people want to rush? There's this, no, not exactly. We all know that assisted conception is now available in Zimbabwe. And there's IVF, there's egg donors, there's sperm donors, and there are people going for implantation and then delivery. Are there any screening protocols developed by the fetal medicine unit? Are you liaising with the specialists, IVF specialists, in terms of fertilization, where you have to profile the egg donor and the sperm donor and also the participants, and in a situation where the embryo is there before implantation, pre-implantation genetic counseling, and what happens, let's say a patient comes to you now, you are the generalist, a patient comes to you with pregnancy resulting from IVF, and is coming in those weeks where you can, that window, where you can now do screening according to these protocols. What is happening? Thank you.
Great. Thank you so much. I think it's a great question, and I think we are going to integrate it in future presentations on this topic. But it's already happening. Before, ladies, couples who have IVF used to do PGT in SA, but I'm glad to announce that our colleague, the reproductive medicine specialist, Dr. Majangara, is now doing PGT in Harare. PGT means before the embryo is implanted, is being screened for aneuploidy. It's already happening locally through IVF center in Harare. So for women who have had PGT, how do we handle their pregnancies? So women who have had PGT, when they come for the 11 to 13 scan, we encourage them to still do the NIPT. The reason why we encourage them to do NIPT is because it has been shown that even post-fertilization, people think some babies, something happens so that some genes of these babies become abnormal because abnormalities have been picked in babies who have done PGT. So women who have done PGT are encouraged to still do the NIPT. If the NIPT is passed, then these women can be reassured that your baby does not have the common chromosomes. If they do the whole chromosome NIPT, they can be reassured that they do not have the common aneuploids that happen on common chromosomes. So that's the care pathway for the IVF group. The most important thing is to know that PGT is already happening. If you have a couple who want to conceive with IVF, our recommendation is that kindly encourage them to do PGT. Kindly encourage them to do PGT. Why do I say so? Because we experience the trauma that couples who jump PGT go through when their babies are discovered to have aneuploidy. Because we have those experiences. When the couple does IVF, they skip the PGT, they come and do NIPT, trisomy 21. We do amniocentesis, trisomy 21, and then they have to terminate. So kindly encourage them to find the extra 2,000. Was it cost an extra 2,000? Because IVF costs 5,000, right? In the SA, where most were doing then. I don't know locally, right? So kindly encourage them to do that, because sometimes it will cost more at the end than 2,000. Yeah, so that is our recommendation, that if you have a couple who say, I want to do IVF, kindly say, please do PGT. Thank you.
All right, thank you so much. So, two announcements. The first one, so as you step out, you need to collect a ticket from the ladies that are seated on the left as you exit. Then we are going to have 2 saving points, food saving points. So if you were dozing, you can get your food from outside here. Then for those who are attentive, I'm joking. So there are 2 saving points. So one is just outside, then the other one at the bar. So on the corridor, straight down. So 40 can be saved this side, and the other 40 the other side. Okay, enjoy. 2 p.m. still remains.
Nice to know you, let's do it again. And we did it on a one night stand. Girl, I wanna be more than a friend. Do ya? It was like food for all of my senses. Our time priceless, no expenses. Like water to all of my trenches. She had a theme song for her every entrance. We had a dinner and a movie. Fire up the tubing. Grade 5, this girl screws closer to me. I call her babe, she call me Boogie. Her beauty intelligence really moves me. Nice to know ya, let's do it again. How we did it on a one night stand. Girl, I wanna be more than a friend. Do ya? Nice to know ya, let's do it again. How we did it on a one night stand. Girl, I wanna be more than a friend. Do ya? This is the very first man over in our relationship. Well, around the graduated with love certificates. Hey, she wanna love her and eyes. This girl screws closer to me. I call her babe, she call me Boogie. Her beauty intelligence really moves me. Nice to know ya, let's do it again. How we did it on a one-night stand. Girl, I wanna be more than a friend to ya. Nice to know ya, let's do it again. How we did it on a one-night stand. Girl, I wanna be more than a friend to ya. This isn't my first money over in our relationship. Girl, around the graduated with love certificates. Hey, she want a lover and me. Stimulated body and mentally. Hey, don't fuss me straight up in your liar. You love me surely if you want to cry. My love is gonna like the mother guys. The love we both sign up cause they are win first prize. Nice to know ya, let's do it again. How we did it on a one-night stand. Girl, I wanna be more than a friend to ya. Nice to know ya, let's do it again. How we did it on a one-night stand. Girl, I wanna be more than a friend to ya. She looking pretty real nice, like the room up, she have the perfect body type. Being with you is like being in paradise. Never seen a girl that can live up to the hype. She is a wife, I'm more pretty, more the mama. Big up to the Caribbean girl, I keep it proper. I'll be Latinos and all of the sexy mamas. Broken Corleone, giving you a holler. Nice to know ya, let's do it again. How we did it on a one-night stand. Girl, I wanna be more than a friend to ya. Nice to know ya, let's do it again. How we did it on a one-night stand. Girl, I wanna be more than a friend to ya. Nice to know ya, let's do it again. How we did it on a one-night stand. Girl, I wanna be more than a friend to ya. Nice to know ya, let's do it again. How we did it on a one-night stand. Girl, I wanna be more than a friend.
What would I do without your smart mouth? Drawing me in and you're kicking me out. Got my head spinning, no kidding, I can't pin you down. What's going on in your beautiful mind? Come on, your magical mystery ride. And I'm so busy, the more it, but I'll be alright. My head's on the water, you're crazy and I'm out of my mind. 'Cause all of me loves all of you. Love you and all your edges, all your perfect imperfections. Give your all to me, I give my all to you. You're my end and my beginning. Even when I lose, I'm winning. 'Cause I give you all of me. You give me all of you. How many times do I have to tell you? Even when you're crying, you're beautiful soul. The world is treating you down and around to every move. You're my downfall, you're my muse, my worst distraction, my rhythm and blues. I can't stop singing, it's ringing in my head for you. My head's on the water, I'm raising it fun. You're crazy and I'm on my mind. 'Cause all could hear me now, singing somewhere through the lonely night, dreaming of the arms that held me tight. You could only hear me now, 'cause I've been too long in the wind, too long in the rain, taking any comfort that I can, looking back and longing for the freedom of my chains, lying in your loving arms again. I can almost feel those loving arms again, loving arms again. Ooh, I can almost feel it. I can almost feel it. Lying in your loving arms. Almost feel it. Almost feel it. Lying in your loving arms. I can almost feel it. Almost feel it.
Yes. Yeah, talk that there is
Also, I wanted to ask, it is normal that when this go up, but a normal room was low, it's so low. So low. Apana ngamukha nje ukuthi ndisime manje.
Where do I get it?
Akuponi. Olatu is now Elma. I think she is eating. I didn't know.
Aripa hapa ya patati.
Yes, Oscar. How are you today?
If you could see me now, the one who said that she would let me roam, the one who said she'd rather be alone. If you could only see me now, if I could hold you now, just for a moment, if I could really make you mine. Just for a while, turn back the hands of time. If I could only hold you now, 'cause I've been too long in the wind, too long in the rain, taking any comfort that I can, looking back and longing for the freedom of my chain, lying in your loving arms again, in your loving arms. Ooh, if you could hear me now, singing somewhere through the lonely night, dreaming of the arms that held me tight. If you could only hear me now, 'cause I've been too long in the wind, too long in the rain, taking any comfort that I can, looking back and longing for the freedom of my chains, lying in your loving arms again. I can almost feel those loving arms again, loving arms again. Ooh, I can almost feel it. I can almost feel it, almost feel it, lying in your loving arms. Almost feel it, almost feel it, lying in your loving arms. I can almost feel it, almost feel it.
Did I ever say how I feel about you? I think I never found that easy to do. Things that you do don't need to be heard. You know your actions, baby, speak louder than words. I've got the fire, bring me a cup, pop the cork and try the sun. When you're empty, I'll fill you up. We'll drink it down till the sun comes up. I'm getting low, like a skin to the floor.
Would you dance if I asked you to dance? Would you run and never look back? Would you cry if you saw me crying? And would you save my soul tonight? Would you tremble if I touched your lips? Or would you laugh? Oh, please tell me this. No,
How would you die for the one you love? Hold me in your arms tonight. I can be your hero, baby. I can kiss away the pain. I will stand by you forever. You can take my breath away. Would you swear that you'll always be mine? Or would you lie? Would you run the night? Am I in too deep? Have I lost my mind? I don't care, you're here tonight. I can be your hero, baby. I can kiss away the pain. I will stand by you forever. You can take my breath away. I just wanna hold you. Oh yeah, I'm in too deep. Have I lost my mind? Well, I don't care, you're here tonight. I can be your hero, baby. I can kiss away the pain, oh yeah. I will stand by you forever. You can take my breath away. I can be your hero. I can kiss away the pain. No, I'll stand by you forever.
For all those times you stood by me, for all the truth that you made me see, for all the joy you brought to my life, for all the wrong that you made right, for every dream you made come true, for all the love I found in you, I'll be forever thankful, baby. You're the one who held me up, never let me fall. You're the one who saw me through it all. You were my strength when I was weak. You were my voice when I couldn't speak. You were my eyes when I couldn't see. You saw the best there was in me, lifted me up when I couldn't reach. You gave me faith 'cause you believe I'm everything.
I wanna be in your life until the night is over. I wanna hold you so tight, coming closer. It's been a hell of a ride, but every single moment you were there by my side. Whenever I'm broken, you make me feel whole. Whenever I'm lonely, you're there for my soul. Wherever Wherever you are, girl, that's where I go by you. Whenever you doubt it, I'll be letting you know. I want to be dancing with you forever. You see through the storm and take me as I am. Maybe it's magic anytime that we're together. I'll make her just love you and hold you for my hand. Hold you for my hand. Hold you for my hand. Hold you for my hand.
Over and over again, yeah, my love is burning, babe. Feels like time is frozen and night is for us. We're alone again, every moment's golden, yeah. Feelings I've been holding in, it must be love. Whenever I'm broken, you make me feel whole. Whenever I'm lonely, you're there for my soul. Wherever you are, girl, that's where I call my own. She's an African queen, she's a melanin. She knows how to open a Benjamin. I got a Mayan queen, I like queen. I see places I ain't never been. No, that's the end of I think I got it in my heart. Open to see and talk to see it. Make me fun. I don't see Samantha. I know there's a Fanta. I can sing a 5-star and Chris Martin, my Coco Bada. Katika mbekada napinda kikokoko ikupe shawada. Cause baby you're my sponono. Cause baby you're my sponono. Cause baby you're my sponono. When you love una risuti como wewe umegeza nemoto hakuna notisira na newe ukameda nikoste lotengeza memory tipeki nibuarori. So they don't know, they just can't my destroy. Kitty one by one, one by one. Kitty one by one, one by one. Kitty one by one, one by one. You and I one by one, one by one.
Good afternoon. Good afternoon. Yeah, people are full. The parasympathetic system is kicked in. Yeah, so we'll try to go through the program and finish on time. So those who are outside, if you can hear us, we're about to resume. How was the lunch? The afternoon sessions are more relaxed than the unemployees, the micro deletions. So we're going to, I think you've seen that we've rearranged the program. So we're going to have two presentations that were in the second session that we have transferred into this session. Then we're going to have the case presentations of different scenarios, and we aim to be done by 5. All right. Cool. All right, so we are going to have our first presentation after lunch, and it's going to take us through the fetal anomaly scan. I think the last presentation had to do with defects. For you to pick defects, you should be conversant with the normal. So you should be scanning in a standardized way consistently for you to be able to pick any deviation from the normal. So fetal defect scanning is not about sort of in all level. I'm not sure if it's true, the red spotting. There was red spotting which was there, but it's about scanning, not coming across the defects by accident or by default, but through standardized, consistent protocols we should be getting through this presentation, which we are going to get from Mr. Simbarashe Chigaye, specialist sonographer, who is keen and interested in fetal medicine. So he will be taking us through his talk. Yeah, so just enjoy the ride as he takes us through the fetal anomaly. Can we put our hands together for him? You can do better than that.
Okay. Good afternoon, everyone. Thank you, Mr. Zanga. Okay, so I'll be taking you through the fetal anomaly scan. So for the fetal anomaly scan, we are going to look at the images that we expect you to produce when you are carrying out your anomaly scan. So the scan is usually performed between 18 and 22 weeks of pregnancy. The anatomy of the fetus should be checked systematically from the head to the toes. So we are going to begin with the assessment of the fetal head. So there are two planes that allow visualization of the cerebral structures relevant to assess the anatomic integrity of the fetal brain. So we have the transventricular plane and we have the transcerebellar plane, but you might also add on the transthalamic plane, which we usually use to measure the biparietal diameter and the head circumference. So to begin with the transventricular plane, so this plane is used to assess the integrity of the ventricles and also the anterior midline structures. So we are going to begin with assessment of the skull bone itself. So the skull bone should be continuous without any defect, and there should be adequate mineralization of the skull bone, so it should be rigid and very echogenic without clear visualization of the internal brain structures and not deformable on probe compression. Then we also assess the shape of the head. So the head should be oval shaped, and there are several abnormal head shapes that you can see that are associated with a lot of different pathologies. So as shown in this image, this is a lemon head shaped, which is associated with spinal bifida. This is a strawberry head shaped, which is associated with trisomy 18, and this is a cloverleaf head shaped, which might be associated with pathologies like thanatophoric skeletal dysplasia. Then to move on into the internal brain structures, what you should see when you're assessing this transventricular plane, you are imaging the head at this level, and your ultrasound probe is this one. So your beam is cutting the head across at this level. So we expect you to see the flux which is dividing the brain, the two hemispheres into two, and then anteriorly an interhemispheric fissure. Then we begin assessment of the posterior horns of the lateral ventricles. So there's an important landmark which will allow you to know the exact position where you are supposed to measure the posterior ventricles. So it is at this level of the parieto-occipital fissure that you are supposed to measure the posterior horns of the lateral ventricles. So we place our caliper from internal to internal. Then our measurement should be less than 1 centimeter. Anything above 1 centimeter, it becomes ventriculomegaly. Then within the posterior horns of the lateral ventricles, we expect you to see the choroid plexus. So that echogenic structure, that's the choroid plexus. And sometimes you might see it with cyst, and it might be associated with chromosomal abnormalities. Then we move on to the anterior part of the head. So from 17 weeks to 37 weeks, whenever you are doing the anomaly scan, we expect you to document this rectangular dark structure, which is the cavum septum pellucidum. So the cavum septum pellucidum will intercept this midline, and absence of the cavum septum pellucidum might be an indication of pathologies like agenesis of the corpus callosum, septo-optic dysplasia, or holoprosencephaly. So when you do not see the cavum septum pellucidum, then you ought to get some additional views, like this sagittal view of the fetal head, which will demonstrate whether the corpus callosum is present or not. So the corpus callosum will be this dark structure anterior to the cavum septum pellucidum. So these other images demonstrating that the corpus callosum is absent and the cavum septum pellucidum is not visualized. There is also a vessel, a branch of the anterior cerebral artery, which is the pericallosal artery, which we see following the course of the corpus callosum. And when it is abnormal, then it will take a different or an abnormal course. So the pericallosal artery is this one, and it follows the course of the corpus callosum, and when it is taking a different course, diverting upwards, then in that case you might be dealing with a case of agenesis of the corpus callosum. Then moving from the transventricular plane that we said, we are imaging the uppermost part of the head in axial plane. We might then rotate our probe so that we might be able to see the posterior fossa structures. So the posterior fossa structures that we assess on the transcerebellar plane will include this cerebellum, and then the cisterna magna, and then we can also see the thalamus, and we should also see the cavum septum pellucidum in this plane. So for the cisterna magna, it's a fluid-filled space that we find posterior to the cerebellum. So we take our measurement of the cisterna magna from the outer margins of the cerebellum to the inner margins of the occipital bone, and our measurement should be less than 1 centimeter. Anything above 1 centimeter, it becomes mega cisterna magna, and there shouldn't be any communication between this cisterna magna and the fourth ventricle that lies over there, but is usually not visible when it is normal. So when we see communication, then we begin to suspect pathologies like Dandy Walker. Then we also assess the cerebellum. So the cerebellum should be butterfly shaped. In cases of spinal bifida or Arnold Chiari, it is pulled back because of the meningocele that is within the spine, and it will obliterate this cisterna magna, and it will become banana shaped. In the front of the head, the shape of the head will also appear lemon shaped, like I showed you in the first image. So in this image, we also expect you to see the thalamus, the mid-flux, and also the cavum septum pellucidum anteriorly. So those are the two images that we want you to produce and document always when you are performing the fetal 18 to 22 weeks anomaly scan. Then we move on to the fetal phase. So for assessment of the fetal phase, you are assessing the phase from this plane. So your probe is directed along this path, and these are the structures that we expect you to see and document. So we want to see the forehead. So the shape of the forehead, it shouldn't have any mass, like in cases where there is proboscis. In cases of holoprosencephaly, we see a mass which is a proboscis, and then the forehead shouldn't be flat, like in cases of microcephaly, which is associated with trisomy 21. Then also we shouldn't see any frontal bossing. Then we should also see the nasal bone. So the absence of the nasal bone is a marker of trisomy 21. So in this case, you can see there is no nasal bone. Then we should also be able to see the maxilla, and without any defect on the gap on the maxilla, which might be an indicator of cleft lip or a cleft palate. Then we should also be able to see the mandible, and the size of the mandible should be normal to rule out micrognathia, and it shouldn't be retracted backwards to rule out retrognathia, which are also associated with a lot of syndromes and aneuploidy. Then we should then from this view now, so if you are able to get this view, it's quite easy. You should just try to rotate your probe so that it is now it rotates at 90 degrees in order for you to be able to see the fetal orbits. So we should see both orbits and document them, and we measure the interorbital distance, and we should also see a thin line, which is the length. Then we can also measure the distance between the orbits to rule out hypotaylorism or hypertaylorism. So these are the images that we expect. If there is hypotaylorism, then the interorbital distance becomes small, and if there is hypertaylorism, then the distance becomes wider. Then from this, on this image also, we rule out any masses within the orbits. As we can see in this image, there are cataracts. Then we move our probe distally to assess the palate. So in this image, we can see the tooth buds in the palate, and we want to rule out any gaps, like in this case where there is a cleft lip and palate. Then we move on to the coronal view, where we assess the fetal upper lips and lower lips, and we should see two nostrils and document them. So there are certain pathologies whereby there is a single nostril, and also we rule out any defects on the upper lips of the fetal lips, like in this case where there is a cleft lip. So these are the images that we expect you to get when you are assessing the fetal head and face. So we move on to the fetal heart. So for a proper assessment of the fetal heart, we ought to get the 4-chamber view, which is the first view that you should always get, and we ought to get the right ventricular outflow tract, the left ventricular outflow tract, and the 3-vessel tracheal view. So we are going to go through them one by one. So this is the 4-chamber view. So you might begin assessment of the 4-chamber view from the level of the abdomen to assess the position of the heart. So the heart should be on the left side, or 3/4 of the heart should be more on the left side. So this is the spine, this is the anterior part of the abdomen. So you draw an imaginary line, and you can see that most of the heart, or 3/4 of the heart, is more on the angle of approximately 45 degrees. So that's the angle that we are talking about. Then we move on to assess the So we move on to assess the ventricles now. So the morphologic left ventricle should be apex forming without anything inside. Then the morphologic right ventricle should have a moderator bend. Then the atrium, the right atrium and the left atrium are almost the same size, so should be the left and the right ventricles. Then within the atriums, we see there should be a foramen ovale, which shunts blood from the right atrium to the left atrium. Then we also assess the ventricular septum. We do not want to see any defects on the septum. Then we also have to see the tricuspid valves that are freely moving, and the bicuspid valves that are also freely moving. So the position that the tricuspid valve is set should be more apical than the offset of the bicuspid valve. So they shouldn't be at the same level where they offset. So if they are at the same level, there's a possibility that there might be a ventricular septal defect. Then we also have to see the pulmonary veins entering into the left atrium with a aorta below, and the aorta should be more on the left. So there shouldn't be any vessels between this aorta and the pulmonary veins. And then we also assess for any pericardial effusions, and the size of the heart should be approximately 3/4 to the area of the entire thorax. So this is for the four-chamber view. Then there shouldn't be any aorta and any overriding aorta seen on this four-chamber view as we see in tetralogy or Fallot. Then we move on to but on this image now, we can't assess the aorta. Now, neither can we assess the aortic valve, nor can we assess the main pulmonary trunk in the pulmonary valve. So we have to go on and then do the left ventricular outflow tract and the right ventricular outflow tract to assess those regions. So for the left ventricular outflow tract now, on this image, you are assessing this ventricle, and you are assessing the aorta, which is originating from the left ventricle. So there are some pathologies whereby the aorta does not originate from the left ventricle. So we have to produce this image to demonstrate that the aorta is originating from the left ventricle, and then there is an aortic valve over there that should be thin and freely moving to rule out pathologies like aortic stenosis. Then we have to see the continuity of the anterior walls of the aorta and that of the ventricular septum. They should be at the same level. This is another image that we can also use to rule out ventricular septal defects. Then we move on to the right ventricular outflow tract. So this is the right ventricle. This is the main pulmonary trunk. This is the area that we are now assessing because we can't see it on the four-chamber view. So we have to see the main pulmonary trunk originating from the right ventricle this time. And then we have to see in this image, it's a bit more clear. We can see the pulmonary valve, which should be thin and also freely moving. When it becomes thick and the movement is restricted, we begin to suspect pathologies like pulmonary stenosis. Then for you to know whether that is the main pulmonary trunk that is originating from the right ventricle, then it has to divide into the right and left pulmonary arteries. Then, because you are assessing this heart at this level, you can see that the aorta is crossing and they are sort of like at 90 degrees to one another. So in cases whereby there is transposition of great vessels, instead of seeing this aorta in transverse, you then see it parallel to the main pulmonary trunk. Then we also move on to the easiest view to obtain, especially if you are able to obtain the four-chamber view. Just tilt your probe towards the fetal head and you get a three-vessel tracheal view. So for this view now, we are assessing the aorta, the arc of the aorta over there, and the main pulmonary trunk including the ductus arteriosus, and then the superior vena cava, which will be coming to the heart. So we assess for arrangement of the vessels, we assess for size of the vessels, and we assess for direction of blood flow. So the main pulmonary trunk and the ductus arteriosus, then the aorta second, and then the superior vena cava. So this is the arrangement that we expect to see with no other vessels in between. Then in terms of size, the biggest will be the main pulmonary trunk, followed by the aorta, and then the superior vena cava. Then direction of flow, the direction of flow within this ductus arteriosus and the aorta should be in the same direction. But for the one in the superior vena cava, because it's coming to the heart, should be in the opposite direction. So that's for assessment of the fetal heart. Then we move on to the fetal abdomen. So we started assessing the fetus from the head, and we moved on to the thorax. Now we are at the level of the abdomen, where we measure our abdominal circumference. So for us to get a proper measurement of the abdominal circumference, there are certain structures that we should always see in order for us to say we have correctly measured it. So we want to see a complete rib, we want to see the adrenal gland, we want to see the stomach bubble, and we want to see the umbilical vein as it enters the portal sinus. So these are the structures that we expect you to see for you to measure the abdominal circumference. Then our measurement should also include the skin. Then when the stomach bubble is absent, then and there is polyhydramnios, we wait and see whether it will appear. If it doesn't appear, then we'll begin to suspect upper GI atresia. And if we have a double bubble over there, another dark bubble like this stomach bubble, then we begin to suspect pathologies like jejunal atresia. Then we move on to the level of the umbilicus, where we assess the cord insertion. So from the abdomen we move distally, then we check if the cord is properly inserted, and we rule out pathologies like gastroschisis over there and omphalocele. Then we also have to check for cord insertion at the level of the placenta. Then we move on distally, where we then assess the urinary bladder and the iliac vessels encircling the urinary bladder. So this is the level that we assess the three vessel view. And in cases where there is a single umbilical artery, then it might also be associated with aneuploidy. Then we also assess the fetal kidneys in transverse and in coronal and also in sagittal plane. So to assess for the presence of both kidneys, we have to see both renal arteries, and then in transverse we can then measure the renal pelvis to rule out hydronephrosis. Then we move on to the fetal spine, which we should always assess from the level of the head to the tip of the spine, because this area is the area where most meningocele happen. So we should see an intact skin, and we should also then follow the vertebral bodies, which should be continuous and without any defect, as we see in this image. Then from there we then assess the extremities, so you should assess the femur and measure the diaphysis excluding the epiphysis. Then you should see the tib fib, the foot, the radius and ulna, the humerus, and also the fetal hands should be documented. Thank you for listening.
All right. Thank you for sticking to time. I think it was being like Charles Mabika, doing a comment non-stop. All right. So when he was presenting, I saw most of you can touch your heart and say, Lord, forgive me for the anomalies I was doing. You're doing probably doing some disservice to, so you can close your eyes and ask for forgiveness from Father Virenga. All right, so if you have any questions, just hold them up. We are about to enter into the Garden of Eden, where we're going to be taken through a journey of the 13th rib by Mr. W. Fende, who is a psychologist. So he'll be taking us through why psychosocial stability is the missing marker in the fetal management and pathways. Can we put our hands together as he comes to the podium?
Sabigano they too like dog. Animals they in human form. Body man nobody like dog.
you're free to move the body. DJ, you can increase the waltz a bit.
You know finish them for my dogs. Them they run them off the couch. I know they come say I do like us. Come they come say we do like us. You know get the time you need it.
You are in the wrong profession, right? DJ. Just reserve the numbers for the after party, okay? All right, so over to you, sir. Can your 15 minutes start now?
All right, good afternoon, everybody, and thank you, Chair, for acknowledging my presence here. And it's an honor to present this 13th RIB to my leadership team and my colleagues here present. I may start off now. All right, I'm going to be taking you through the 13th RIB, why psychosocial stability is the missing marker in the fetal management pathways. By the way, I am family therapist W. Fende, stationed at Salem Mugabe. All right, let's go on the core premise or the introduction. FMU specialists are trained to identify the subtlest structural anomalies, for example, the nasal bone, nuchal translucence. Then we are now focusing on the missing metric. While we standardize the physical markers, we often overlook the psychosocial marker. A critically perfect referral pathway fails if the human engine is in a state of psychological collapse. So what do we mean? These specialists, if we get into the scan room, everybody will be like, oh, we are looking maybe for trisomy 21, the extra copy. We are looking at haloprosencephaly, anencephaly, hydrancephaly. But there is a missing marker psychologically. We are helping the patient, yes, to diagnose the fetal anomalies. But yet we are forgetting about one aspect. For that patient to adhere to any medical advice or any medical information, they need to be psychologically stable. Most of them, they fail to receive and process the information better because they have anxiety, they have distress. Some of them, they even have PTSD, post-traumatic stress disorder. Allow me to proceed. All right, so now, the 13th RIB now is fostering psychosocial support. Here we go, defining the 13th RIB in FMU, fetal medicine unity. Marker definition: psychosocial stability is the patient's capacity to process, retain, and act upon complex medical information under high stress. What this marker is, it is just as an extra RIB may indicate chromosomal risk, emotional dysregulation indicate referral risk. Let's say we have diagnosed a patient for at least, let's say, we screen for trisomy 21. Then be like, oh, this is not the actual diagnosis, you need to go for NIPT. Right. The patient is not psychologically, did not go through the psychological help or the counseling audit. The next thing, they'll have that maybe let's say the unemployed sheet, they will take it home. They will not come back. Why? Because they are psychologically overloaded or overwhelmed. So the reason why we are saying it is a missing marker now, we have many individuals who are going and not retaining. That is the aspect that I would like to highlight here to show the importance of mental health in the fetal medicine unit. Let me proceed. Okay, how do we do this now? At first we have to run an element what is called this anxiety screening. Is there anyone who knows what this anxiety screening is? Okay, allow me to explain a bit. Anxiety screening now, this is the process whereby a therapist or a counselor, a psychologist, a family therapist, now they are screening anxiety related to the scan. If we take a patient straight into the scan room, they have anxiety, they are more likely not to understand what you are telling them, the results that you are giving them. There are many case studies whereby a patient comes out from the scan room, what is the diagnosis? They say, my baby is a Down syndrome and they might die. So there is the importance of screening before they get into the examination room or the scan room. The second thing that what we do, it is the pre-scan therapy audit. After screening them for anxiety, we now go into a counseling session, which is a pre-scan therapy audit. We will be now helping the client to stabilize, to ease the anxiety that we would have found. Now to prepare them for anything that is going to come and help them to understand that they are not the ones to blame for anything that might come out from the scanning room. An individual remains as an individual, a condition as a condition. Now we go on, after the scan, we now start by introducing an insight of understanding checklist. This is a teach-back method we have designed to check if the client has clearly understood the condition or the results of the scan. There was a problem where patients could not even interpret, or you could not even tell the next person what they were told in the scanning room. So if we run this checklist, it has a series of 6 questions. Now, if we run it, then we find no, the patient is not eligible for going. We would recommend the medical team to reintroduce or foster or to give back again the information just to teach the patient again. All right. After we run the checklist and now we assess that this client or this patient is eligible for post-scan therapeutic audit, we now take them now. We are trying to stabilize them from the distress of the condition, whereby we introduce the choice theory or the reality theory, whereby we now say we have the locus of control. So you need to focus on things that you can control, the emotions, your actions. You cannot control the diagnosis. So now this will help the patient to reach the level of informed decision. That is when now they will say, okay, I need termination, I have thought of this. All right, then lately the 5th one, now we do follow-up sessions for each and every patient that we would have seen and assessed. All right, so this is now the procedure. It is similar to that of HIV testing. So what happens at first now, we're saying we are screening the patient at first for anxiety, the anxiety related to the outcome of the scan. Then we go to the next stage that I have explained. I'm not going to explain the whole of it now due to my time, so I'm going to run. I'm just giving you the picture so that maybe your eyes will get a little bit of attraction. All right. Now, I want to dive more. I have just few slides to explain a bit. Okay, there are impacts of failing to introduce psychosocial support to these patients. Then sometimes you can say patient, they reject the results. This is not mine. They go. They fall into hiding now. Why? Because they have stress. They have anxiety. So now the importance will come. All right. There is also severe anxiety, which becomes the impact again. Let's say the baby is 18, or maybe they have clubfoot, bilateral clubfoot. Now they'll be like, what if my other pregnancies also follow suit? I think I'm not even well fit to give birth again. They have now anxiety of falling pregnant again. All right. They also have the flat affect. They become numb. They actually become numb. They be busy. You're talking to them. They're on that scanning bed. You ask them a question. No response. They become numb. Why? Because we did not prepare them enough for anything that is going to come out from the scan. Allow me to proceed to the next slide. Okay, there is the anatomy of a break. Why standardized pathways fail? These are now the reasons why we are failing to produce the standardized pathways. All right, let me start. There is what we call the amygdala hijack. When a mother hears a fetal abnormality, the fear center of the brain takes over. You need to code this. Okay, there is the cognitive narrowing, whereby high cortisol levels physically block the prefrontal cortex or the logic center. We are saying the fear now takes over. They are no longer using the logic. They are now using the fear or the distress pattern now. So at the end of the day, they might say, terminate this baby, but yet they haven't gone through the procedure of processing the result, processing the diagnosis. All right. This explains why patients forget follow-up dates or misinterpret doctors' instructions. It is not lack of intelligence, but biological overload. We cannot have a standardized response from a non-standardized emotional state. We have two case studies, so I'm just running to finish. Okay, this is the first case study here of MKE 21. This is a pseudonym, a code name. Okay, the diagnosis is trisomy 21, bilateral ventriculomegaly, gravida 1, para-O. The intervention which was used was rapid prediction to medical action based solely on anatomical marker. Then the failure now, where the failure comes on, what was the absence of a counseling audit or assessment. The result was development of post-decision dissonance. Okay, when I talk about post-decision dissonance, I understand that most of you here, you have men clothes in your wardrobes, you take this one, then you put on, then when you are now on the way, it's like, I was supposed to wear that one, but why am I wearing this one? So what is post-dissonance? It is when your brain magnifies the flaw of the choice you made, and also it starts to romanticizing the path you left. So it is a conflict inside your mind. So this patient, the patient was diagnosed of trisomy 21. Then they say, I want to keep the baby. But after giving birth, they now face the reality. There comes the conflict. I should have at least terminated. my family, my society, everything is now down. There are now development of post-stress traumatic disorders, mood stress. They are no longer fit to take care of the baby, but they have already made the choice. So we as psychosocial supporters, we are there to support the choice that you made. We cannot ask you, change this. No. We will support. Through what? We make you see the pros and the cons. If you choose to keep, if you choose to terminate, that's your informed decision. So that's what happens. Now, we want to show how psychosocial support is a missing marker in FMU. Now, it now proves that this patient skipped the pre-scan screening and audit. They only received the post-scan audit. So now we help the patient to form an informed decision, yet we haven't helped her stabilize before the scan. Why? Due to pressure. Due to a lot of patients that needs us. So you will see on the recommendations what we would love to be introduced so that we will help these patients with NH. All right. The second case is of a client S2R, diagnosis polyhydramnios and severe thoracic anomaly, gravida 2 and para 1, mental state decision made in a mental fog indicating a lack of cognitive clarity. Procedural gap, decision reached without counseling audit. Then the outcome was a high risk of post-traumatic stress disorder accompanied with post-decision dissonance. The patient now was diagnosed with this thoracic anomaly. Then they say, oh, I want to terminate the baby. They just made a decision. While they were in a blur imaginary vision, the mental fog. They were in a mist. They haven't even processed the diagnosis. Why? They lacked pre-screening, pre-scan counseling audit. They just made into counseling room, okay, into a scan room, okay, I was scanned and my baby, they have a short and bent femur, so I need termination. But it's not it. We're saying a patient needs to process. We have a guideline that we designed in the fetal medicine unit as family therapy psychologists and counselors. We tried to encompass this. At least a patient needs at least 24 to 48 hours of processing the diagnosis before we help her or we help him form their informed decisions. All right, let me move. Okay, so to do that patient here, they are mixed now. The mental state is in a rock mix. They are not even stable. They are just the mind is blur. They made the decision. After making a decision now, they start regretting the decision. I should have kept the baby. There are many people with similar babies. No, I made the wrong choice. Now they are developing a guilty conscience. They are blaming themselves for taking the route they have taken because they lacked psychosocial support. That's why I am clearly emphasizing that psychosocial support, it is an important element that needs to be recognized, acknowledged, and also implemented in all FMU units. Without that element, it is a missing marker. So FMU now becomes it only stands in the medical side, but neglecting one mental aligned thing, which is the psychosocial. A human being is formed into OS2. We have the biological setup and also the emotional setup. So to help that patient receive the ultimate and best point of care, we need to integrate both of them to form a single result which is the best. All right, the conclusions here, the mind guides the management. So if the mind is not stable, they are more likely to provide information which is biased, and lately they will blame and they will start questioning more. All right, precision requires context. So we are saying we are not only scanning these patients, but we also need to introduce, I would like to term this, we have sonography, so we also have sonopsychology. So we need to employ this so that these patients, they'll have a proper point of care. Stress rewires patients and provider. It's not only the patient here that we're talking about, also the provider. If you are in a state where your mind is not stable, you're more likely to provide biased information. You are going to miss a lot of things. So your mental health needs also to be cared of. So there must be brothers keepers, sisters keepers in the FMU unit. Burnout can also lead you astray. You end up talking to these patients in the manner that is out of bound. FMU leadership to implement standardized counseling review clinics, empowerment of frontline clinical staff to do task shifting with checklist. So we are saying in the absence of a counselor, a psychologist, or a family therapist, any frontline clinical staff who is present can also use the checklist, the instructions, can also use the screening tool, the anxiety screening tool, to assess the eligibility of a patient to go through the scanning process. Okay, we also recommend creation of more workshops that enlightens how mental health is important in the FMU department. Right, thank you so much. I would like to sit.
Do you want more time? That was too short. Yeah, we allow you to sit. What an insightful presentation. We learned about this anxiety. The sonopsychology. Were you creating these things here? Do they really exist? All right. So yeah. So probably these two presentations, I'll just ask for some quick questions before we move on to the case series. During the case series, I will be introducing my new tool called the time anxiety. So for the registrars, your bosses are here, so time management will be part of your continuous assessment back. All right, so I will entertain some questions from the anomaly scan, where many were found to be on the wrong side, and also the cycle 13th rib.
Thank you for those insightful presentations. My question is to Mr. Chigayo. What are the appearances of in a male fetus with posterior urethral valves? Hello?
Okay, so for a male fetus with posterior urethral valves, usually the bladder is very distended. It will produce what we usually term the keyhole sign, whereby it's narrow at the beginning, then it becomes wider, forming what we call that keyhole sign. So because there is blockage, the bladder is overextended, and then you can also make use of nomograms to see whether the bladder volume is within the normal limits for that particular gestational age. Then when it is extensive now, it will also lead to dilatation of the urethra, and eventually of the ureter, and eventually hydronephrosis within the fetal kidneys.
All right, any more questions? All right, no questions is good for me. All right. Okay.
Thank you. I just want to comment, Fende, for the wonderful presentation. I think his presentation is just telling us that we all need to be taught, because the assumption has been doctors know how to counsel patient or know what is going on in the patient's mind, but the reality is that it's not correct. So this change of practice, which we are introducing in the fetal medicine units, should cut across all disciplines, because there's a lot of bad news that patients are being told in clinical rooms, hospitals, whether labor or telling a woman that there's no fetal heart, or telling a woman who has been done a seizure to save her baby, then she's going to be told that your baby is a fresh tubers. So this calls for a change, this paradigm shift, to know that we cannot work alone. Because most of, okay, for us in our discipline, we are the bearer of bad news to people. So it's high time that we begin to embrace other disciplines in our clinical work, because without them we continue to cause a lot of suffering. I think he showed the example of suffering. We are already working with them, but you can see even in their presence, the suffering there is still there. Probably we need to fine tune how we are doing things, like he's teaching us here, that we need to book these patients with them first before they even see us, because we are the stressors. So yeah, so there's a lot to learn in our clinical practice is to be reshaped. The traditional practice where the doctor is the alpha and omega of patient care is over. That kind of traditional approach. Patients need more than what we can offer in our individual parts. Thank you.
All right, can we put our hands together for the presenter once more? You're sure you finished all the slides you had? You didn't cut some, because that was too good. And I think you're also in the wrong profession. You should be a pastor. Because I was about to be convinced to also become a family therapist. All right, so, all right. You came before I called you. All right, so this is our next presenter. You'll be taking us through complex pathology, Doppler changes in trisomy 21, a case series at a tertiary institution in Zimbabwe. So your 10 minutes start now.
Okay. Thank you very much, Chair. A very good afternoon to everyone. I'm going to present on complex pathology Doppler changes in trisomy 21, a case series at a tertiary institution in Zimbabwe. So I'm going to start with a case of Miss MM. Miss MM, who is 34 years old, and her spouse is 35 years old. She came to us, she was in her first pregnancy, and we started seeing her at the gestational age of around 9 weeks, and we went through her pregnancy together up to 38 weeks. She was referred to Salim Mugabe Central Hospital with an ultrasound scan in the first trimester, which was showing that there was knockout translucence and ventriculomegaly. And both the Miss MM and her spouse employed with a monthly income of 600 to 700 United States dollars. During pregnancy, they had a torture screen, which was negative. Oral glucose tolerance test was done, and it had normal results. So this is the summary of the ultrasound scan. When she came to us, we noted that she had an intrauterine single viable fetus with normal growth, severe ventriculomegaly of lateral ventricles, and there was knockout translucence. There was a ventricular septal defect measuring 3 millimeters. There was increased pulsatility index, and at some point absent end diastolic flow in the umbilical artery Doppler, and the ductus venosus had a reduced A wave at 2 of the visits which she made when we were scanning her. Then at this point we made an impression of aneuploid, and we requested for amniocentesis and karyotyping. Fortunately, the couple managed to pay for that, and this confirmed trisomy 21. So we conducted a multidisciplinary team meeting, and they underwent counseling, and options included termination of pregnancy. However, the couple opted to keep the pregnancy because of religious reasons. And also it was their first pregnancy. So just a few slides which are coming, I'm just going to indicate some abnormalities which we noted. So if you look here on this picture here, which is showing the fetal head here, and this is the back of the fetal head, which is showing that there was an increased knockout thickness here. On the other picture here, this is a transverse section. It's a transverse section at the left of the heart, where we see, if you see the blue there, it's showing us that there was a ventricular septal defect, and this was measuring about at this point it was measuring about 1.7 millimeters. On this particular picture here, this is still the fetal head, and this is the posterior horn of the lateral ventricle, where we see that the measurement of the lateral ventricle was about 15 millimeters, which was severe ventriculomegaly. The same goes on the other side of the ventricle, so this fetus had severe bilateral ventriculomegaly. Here I am showing you the waveforms of the umbilical artery Doppler at various, at different gestations when we saw this mother. So here it was a 24 weeks gestation. If you remember the talk we had on Dopplers, we see that this umbilical waveform had a high pulsatility index there. We can also see it by eyeballing. Then at 35 weeks, there was actually absent end diastolic flow within this umbilical artery waveform. And now I'm showing you, we started to see Miss MM, and we see that the estimated fetal weight was kind of on the lower margin here, but within the normal range. Here I'm showing you the trend of the umbilical artery pulsatility index. Instead of following these normal trends here, we see that the PI here was actually increasing in the opposite side. And at 36 weeks when we last saw her, it was actually up there. So we followed up Miss MM, and she was scheduled for an elective cesarean section at 38 weeks, where a live baby girl was delivered with an APGAR of 7 and 8 on 1 and 5 minutes respectively, with a birth weight of 2,490 grams. So this is the photo of the newborn. Here we see some of the features here: low set ears, there were slanted palpebral fissures, we covered that. If we see on the right foot here, there was seen ductile here on the right foot. So this is a summary of Miss MM. So I've presented a 34-year-old who was diagnosed, confirmed to have a fetus with trisomy 21 and developed abnormal Dopplers within the umbilical artery, which started mid-second trimester and worsened in the third trimester, who then underwent a cesarean section, giving birth to a live baby. This is second case of Miss R.A. Who was 35 years old in a 5th pregnancy with 3 children at home, referred to us again at Salem Gabi with an ultrasound scan showing an enlarged fetal kidney at 23 weeks gestation, and Tosh's screen was also done. It was negative. Oral glucose tolerance test was done and the result was normal. A summary of the ultrasound scan findings: there was a single viable intrauterine pregnancy showing normal growth across the whole of the pregnancy duration, bilateral mild ventriculomegaly and hydronephrosis with polyhydramnios. Again, a ventriculoseptal defect measuring 4.9 millimeters, increased pulsatility index, and at some point reduced. At the end, the last time we scanned her, she had absent end diastolic flow in the umbilical artery. And in this particular case, we suspected aneuploid as well. However, the parents could not afford to pay for karyotyping. So in the MDT again, options included termination of pregnancy. They underwent counseling as well, and they opted to keep the pregnancy for the same reasons of religion. Now, just a few pictures of the ultrasound scan. Here we see the prefrontal thickness. Here is showing that it was thickened. Here the transverse section at the left of the heart. Again, the ventriculoseptal defect that I've talked about. This is the fetal head here, showing again the lateral ventricles there, and there was mild ventriculomegaly of 11.2 millimeters. Transverse section at the level of the kidneys there. We see one side there was hydronephrosis marked there, and as well to some level on the other side. The Dopplers, umbilical artery Dopplers here, we also see that there was increased PI in the umbilical artery Doppler, and this is the waveform at 26 weeks. At 33 weeks, apologies, this was actually at 36 weeks. At 33 weeks, she had absent end diastolic flow in the umbilical artery. Here at 36 weeks, it was actually reversed, if we can see this particular waveform here. So now I'm also showing you, lastly, again, the nomogram here for estimated fetal weight, showing that the growth was actually as expected. Now, the nomogram of the umbilical artery Dopplers, the pulsatility index was actually increasing with increasing gestational age. So at 36 weeks, Mrs. R.A. came to us for review, but she was complaining of low abdominal pain and backache. And in view of the reversed end diastolic flow in the umbilical artery, she was ordered to have an emergency cesarean section, which was done and led to delivery of a live-born infant who was actually doing well. So in summary, in this particular case, I have presented a 35-year-old who was suspected to have a fetus with abnormal umbilical artery Dopplers, which worsened during pregnancy, and lastly underwent an emergency cesarean section, leading to delivery of a live baby. And both of these women were discharged home, and they are being followed up by the pediatricians and as well by the neurosurgeons. So the major finding, the common finding in these two particular cases is that there was abnormal fetal Dopplers, especially the umbilical Dopplers in both cases, with no evidence of fetal growth restriction. And the question is, what can actually be giving an explanation to these findings? Could it be some subtle changes within the function of the placenta, or in the such that there were no abnormalities picked on the ultrasound scanning, whilst they were actually giving rise to abnormal Dopplers? Or could it be something peculiar to trisomy 21 in this particular case, which gave a result of these abnormal Dopplers? So that's the question which we had after having these two particular cases. Another major finding is that the routine ultrasound scan led to suspicion of trisomy 21 and resulted in the diagnosis in the first case and still suspicion in the second case. So I'm just going to give just a short discussion on some of the studies which are there to try and explain these particular questions. This is a study, a retrospective cohort study with an objective to demonstrate Doppler patterns across gestation in fetuses with trisomy 21 compared with euploid and investigate their association with pregnancy outcomes. It looked at 86 fetuses with trisomy 21 versus 130 fetuses who had normal, who were euploid. The results, summary of the results is that approximately 56% of the fetuses with trisomy 21 had at least one Doppler above the 95th percent. And at birth, 3.9% of the trisomy 21 fetuses were small for gestational age, meaning around 92% had normal weight for their gestation. So when they stratified, they then took a group of those fetuses who had normal growth. They looked at the status of the umbilical Doppler waveforms. They noted that still the umbilical artery Doppler indices remained higher for that particular group. Even for the 9.3%, it also remained higher. And they actually followed through the histology for the placenta for both groups to see probably if there were subtle changes within the placenta which could not be giving abnormalities to be picked by an ultrasound scanning. And they noted that the placentas were normal in more than 90% of the fetuses who had trisomy 21. And their conclusion was reference intervals based on euploid fetuses may therefore not be appropriate for antenatal surveillance of fetuses trisomy 21. Probably this group of fetuses, they need their own reference ranges. Another study here, which had an aim to examine the umbilical artery Doppler flow patterns in late third trimester fetuses with trisomy 21, a retrospective study of fetuses with trisomy 21 that were evaluated from 33 weeks gestation. And there were 42 of them which met the criteria. And in 57% of them, the pulsatility index within the umbilical artery Dopplers remained again above the 95th percentile. And umbilical artery PI was not dependent on the abdominal circumference and other growth parameters. So they concluded that in half or third of trimester of the third trimester fetuses with trisomy 21, the resistance in the umbilical artery increased even in the absence of placental insufficiency. So I'm going to skip. I see that is looking at the time. So here, I'm just going to jump to the last here. I went through literature trying to check if there are any guidelines which are specific to say for couples who opt to keep pregnancies of fetuses with trisomy 21, what could be the well-informed trajectory of following up these particular fetuses. So I only managed to see a hospital-based guide here, but I could not find any other guidelines from be it FIGO, be it NICE, and so forth, which were actually guiding on how to follow up these fetuses. Here they said ultrasound scans at 28 to 32 weeks and at 36 to 37 weeks gestation are necessary to follow up these fetuses with trisomy 21, and induction of labor at 39 weeks to avert mortality, which may not be explained. And the conclusion, which I am giving according to this short presentation, fetuses with trisomy 21 are often have abnormal umbilical artery Dopplers that may actually worsen. Hence, close fetal Doppler follow-up is warranted, especially with advancing pregnancy. And the recommendations, some of the recommendations are addition of an ultrasound scan monitoring strategy for fetuses with confirmed or suspected, like in the second case, to have trisomy 21 may be advantageous to be involved within the FMU protocol. And lastly, given just these two cases, and I've presented retrospective studies which are known to have some inherent weaknesses, probably a prospective study might actually give us local evidence which may help us to manage these fetuses and also to know the trends or the outcomes after delivery. Thank you very much.
We can do better than that. All right. I had forgotten my time, my stopwatch. It's almost like Manchester United is playing Manchester City, and I gave the whistle to a Manchester United player, so they were not blowing to end the match. All right, so just hold on with your questions, just write them down as we entertain the next presentation, which is taking us through gastroschisis. So to be doing that, we've got Dr. A. Kuwaoga, whose 10 minutes start now. So your 10 minutes start now. I'm no longer giving. Let me put it here. When I take it, you know that, yeah, time is up.
All right. Thank you, Mr. Zanga. So I'm going to begin my very short presentation by giving you a brief background on gastroschisis, which is a congenital full-thickness periumbilical abdominal defect with the visceration of bowel into the amniotic cavity. So prenatal diagnosis enables surveillance, delivery planning, as well as immediate neonatal surgical intervention. Despite improving survival in these patients, optimal timing of delivery and predictors of adverse bowel outcomes remain debated, but I'm going to share a few of the recommendations according to the American College and the Royal College of Obstetricians and Gynecologists. So against this background, I'll present a case which was managed through multidisciplinary collaboration between the fetal medicine specialists, the obstetricians, the neonatologists, as well as the pediatric surgeons. So I'm presenting a case of let's call her Miss MS, a 20-year-old woman from Chinoi. She was para O plus 2 gravida 3 with 2 unexplained second trimester miscarriages. So this pregnancy was planned, however it was booked late, and this late booking probably limited opportunities for earlier anomaly detection. We know Dr. Verenga actually told us we can diagnose gastroschisis even in the first trimester. She was then referred to Salim Gabe Hospital at 33 weeks following ultrasound scan suspicion of gastroschisis. So this is a patient who had 3 antenatal visits during the current pregnancy, and these were significant for detection of gestational hypertension, which was diagnosed at 24 weeks. It was, however, well controlled on nifedipine. She did not have any other known chronic illnesses and did not drink or smoke, and when she presented to us, she was at 34 weeks plus 1 day. So at this time of her presentation, our main concerns were to confirm the diagnosis by doing an ultrasound scan, as well as to assess for associated bowel complications, as well as to evaluate the fetal growth. So this is the transverse section showing the fetal head, and this had normal measurements for the biparietal diameter as well as the head circumference. And then we also have measurements for the abdominal circumference, which was low in the 3rd percentile, and femur length, which was at 3.5. So the abdominal circumference should be interpreted with caution, because this is a patient who had a visceration of the abdominal contents. So it would definitely overestimate the finding. However, because we also have a low femur length, this fetus was then diagnosed with asymmetric fetal growth restriction. And then this is just a transverse section showing the abdomen with herniated bowel through the anterior abdominal wall. Of note, you can see that there is no membrane covering the bowel, which then differentiates this finding from omphalocele. And then this is sagittal section showing the herniated loops of bowel. And at this stage, it is important to note that there was no significant bowel dilation or wall thickening, which would then signify complicated gastroschisis. And then we also did an amniotic fluid assessment, which was normal. And it is also very important to note that the amniotic fluid did not have any signs of meconium staining or inflammatory exudate, which also gave us an impression of uncomplicated gastroschisis. The rest of the fetal organs were essentially normal. And then this is the Doppler assessment showing normal umbilical artery and MCA Dopplers. And these are important since this is a patient, this is a fetus which was growth restricted. The placental function remained normal. The fetus also had normal ductus venosus Doppler waveforms, and this was also very reassuring in light of the low biometry measurements. So overall, the findings were consistent with isolated gastroschisis complicated by fetal growth restriction, which was asymmetrical, without any evidence of bowel obstruction, perforation, or fetal compromise. So this fetus was discussed in a multidisciplinary team meeting involving the neonatologists, the pediatric surgeons, the fetal medicine specialists, as well as the obstetricians. And the discussion centered on the poor outcomes that these gastroschisis babies have in resource-constrained settings like our own. So a plan was made to plan for a cesarean section, for an elective cesarean section with immediate neonatal assessment as well as bowel reduction. However, before the date for the planned C-section could arrive, the patient then went into preterm labor at 35 weeks and an emergency C-section was performed. A male neonate was delivered with good APGARs of 8 to 9 at 1 and 5 minutes respectively. And he was then admitted into the neonatal unit. So on these images, we see the fetus at day 0 post-delivery, with the urine bag acting as a silo to keep the bowel contents sterile and free from infection. And then at day 2, we see that there is decrease in the size of the bowel contents, and this was after the staged reduction. And at the time we are presenting, the reduction was still ongoing. So just a brief discussion on the fetal surveillance and delivery considerations for fetuses with gastroschisis. It is important to do serial surveillance for fetal growth and bowel complications. These fetuses tend to have growth restriction due to the increased metabolic demand of the bowel contents that are within the amniotic cavity, as well as protein loss from the bowel loops themselves. And as I said earlier, the reduced abdominal circumference may reflect reduced intra-abdominal contents, so may not necessarily mean that the abdominal circumference is low. Doppler assessment guides detection of superimposed placental insufficiency, and it is important to deliver these fetuses in a tertiary center. The optimal time of delivery remains controversial. However, ACOG as well as the RCOG recommends delivery between 37 and 38 weeks. So the outcome is largely determined by the presence of complex gastroschisis. As I said earlier, this includes bowel perforation, volvulus, as well as wall thickening of the bowel. And the management includes primary closure if the defect is small and the bowel contents that are within the amniotic cavity, if they are not too large, or stage silo reduction was done in this case. The morbidity includes sepsis, intestinal failure, as well as prolonged hospitalization. Our patient has been in hospital now for about 30 days, so it's a good example of this. Resource limitations significantly influence the neonatal outcomes. These patients tend to do better in high resource settings. So just a few learning points. This case reinforces that gastroschisis can be reliably diagnosed antenatally, as we had earlier in the first trimester. And surveillance should focus on fetal growth, bowel appearance, as well as Doppler evaluation to rule out complex gastroschisis. And just to reiterate, reduced abdominal circumference may not always represent placental insufficiency alone. Delivery should occur in a center with immediate neonatal surgical capability, so in a center with pediatric surgeons, and resource availability remains an important determinant in terms of outcome in low resource settings, particularly for the morbidity and the mortality for these fetuses. Thank you.
Excellent. Can you put our hands together? She has passed the Tanzania. 9 minutes, 11 seconds, and 33 milliseconds. Yeah. Well done. So you have, at least you already have 10 marks. Continuous assessment. All right. So if you are a sonographer or an obstetrician who does scans, or a midwife, and you have not seen any of these many pathologies, then you are not scanning according to protocols. Because at least you should at least come out. There are many pathologies. So if you have not come across at least one, but you will not get these pathologies if you have your 10 images, which you do in 3 minutes, 33 seconds scan. All right. So the last presenter here, before we go into a series of questions, will be taking us through the double bubble in utero, a case of duodenal atresia in trisomy 21. So you have to beat a record. She did 9 minutes, 11 seconds, and 33 milliseconds. So time starts now.
Thank you, Mr. Zanga. Good afternoon to you all. I will do my best. So today I will be presenting a case of a combination of duodenal atresia and trisomy 21. So this is just building upon the discussions that we've been having on the importance of aneuploidy screening and the potential fetal defects that we may find, just to show you that these are practical things that we meet and are clinically relevant. So I'm presenting a case of a 27-year-old who was in a second pregnancy, and we saw her for the first time at 32 weeks. She had been referred from a local clinic after having gone for an ultrasound scan which showed polyhydramnios. So when she came in, just of note, she came almost 2 months after the referral. So when she then came in, she was complaining of low abdominal pain and backache, and she had associated dysuria. And of note, she was not perceiving fetal movements. Her pregnancy had been booked 2 days prior at the clinic, and there were no hypoglycemic symptoms, no diabetes screening, and because of that poor booking, she had missed aneuploidy screening. Anatomy survey had also not been done, and the first pregnancy was uneventful. On examination, she was otherwise normotensive, vitals were normal. However, she had mild respiratory distress and was complaining of significant abdominal discomfort. The abdomen was tense, it was non-tender. However, the hypothalamus was quite large at 41 centimeters. The fetal parts were not palpable, and the fetal heart could not be heard with the fetoscope. On examination by the admitting doctor, they noted dilatation of 3 centimeters and membranes were intact. She had no show. They made an impression of query preterm labor, query UTI. She was admitted, sodium dexamethasone course, and an ultrasound scan was ordered. So the initial routine scan that was done, day 2 post-admission now, noted a singleton live fetus. The weight was 1,734 with polyhydramnios and abnormal Dopplers, as highlighted by Dr. Shliwayo. Reduced endostolic flow in the umbilical artery. MCA was also increased endostolic flow with notching in the uterine arteries. Recommendations were made for further testing. She then came for the specialist clinic in view of the polyhydramnios, and we noted that in terms of the biometry, she actually had an estimated fetal weight. So all parameters were below the 10th centile, and the estimated fetal weight was at the 7th centile, and the Dopplers were also abnormal. So this was just a few images to highlight the abnormalities that we noted. So initially we noted what we were terming the double bubble sign. So this is, sorry? Okay. So this is just the double bubble sign. It represents an image of the stomach and also the duodenum, the proximal part of the duodenum, and this middle part which showed the area that is atretic. And this next image is just highlighting the polyhydramnios, which was at 17.8 centimeters. And then we also noted, because we saw this fetal defect, it's also very important to then look for other fetal defects which might point towards a particular syndrome. So we also noted that the fetus had a ventricular septal defect, is highlighted here with the calipers, and also we noted there was an absent nasal bone. So due to the tense polyhydramnios and the patient's discomfort, we decided to do cervical length, and the cervical length that was done at that point noted that she had a cervical length of 2.8 centimeters, and the cervix was long and closed. So we went on to do amnio reduction. 3.4 liters was drained, and a sample was actually collected for karyotyping, because at this point we were concerned about trisomy 21. So the patient, however, 30 minutes later, as we noticed some of the complications of amnio reduction, actually went into labor, had worsening contractions, went on to deliver a live baby boy within the hour with an APGAR of 3 to 5 on 10, and also low birth weight of 1,600, and was admitted into the NNU. So this is just an image of the baby, just showing the epicanthal folds. Sorry, this is not showing the ears, but they also had low set ears, a flat nasal bridge, and also had a simian crease. So day 2 post-admission, they unfortunately had no NGTs available. However, they kept NPO and on supportive management. Day 5, they underwent a laparoscopic duodenal to correct the duodenal atresia. But however, the patient demised the next day. So in general, with isolated duodenal atresia, we do tend to have good outcomes. 95% of these clients, neonates, actually survive. However, with our patient, there's a constellation of associated possible trisomy 21. There's also, there was the element of prematurity. There was also the element of low birth weight, and also this associated ventricular septal defect, which added to the complications that, the potential complications, and also succumbing to this procedure. So I'll just go through a quick discussion to note what would be the impact of trisomy 21 on duodenal atresia in terms of management and outcomes. Is there any difference to a neonate who might not have aneuploidy screening? So duodenal atresia is a significant cause of neonatal intestinal obstruction, and it occurs in 1 in 5,000 births. And duodenal atresia is actually associated with other chromosomal abnormalities, as we noted, particularly trisomy 21 that we suspected in this patient in 25 to 30% of the cases. And the global pooled prevalence of duodenal atresia in those with trisomy 21 is 3%, and there's no gender variation. As a solitary finding, the risk of recurrence in the next pregnancy is quite low. However, with association with other congenital anomalies, recurrence can go up to 50%. So association with other congenital anomalies is up to 50% of the cases. So it's also very important to screen for other anomalies, particularly the congenital heart defects, like we did for this client, and also other gastrointestinal abnormalities, because they might also have esophageal atresia. So these often then determine the overall prognosis, the risk of recurrence, mortality, and how you are going to then counsel the patient. And further investigations will be needed to characterize additional defects like an echocardiogram and also genetic testing. In terms of outcomes of duodenal atresia in trisomy 21, while the isolated one, like I mentioned, has excellent prognosis, when we have trisomy 21, it then alters the survival rate. Single-center studies have shown conflicting results, with some studies, one done in Thailand, actually showing higher rates of post-op complications and mortality in patients that have trisomy 21. And this was attributed as to like our patient congenital heart defects and also respiratory tract infections. And those with isolated duodenal atresia were noted that the trisomy 21 diagnosis was actually an independent risk factor for mortality. In comparison, however, other studies actually noted no differences in these outcomes in terms of post-op complications and mortality. Like I said, there's conflicting data. However, a larger study, a population-based study in the UK, on the impact of trisomy 21 on duodenal atresia, its epidemiology, management, and outcomes, found that those infants who underwent surgery, cardiac anomalies were common in trisomy 21 patients, and associated GI anomalies were less common. And there was no differences in the type of surgical management that was offered, in the time to full feeds, in essential repeat surgery or mortality. However, there was a difference in hospital stay. So in terms of the role of early detection, Cohen noted that prenatal diagnosis resulted in earlier confirmation of the diagnosis, which was not done for our patient, and more appropriate care post-delivery. However, deliveries were noted to occur earlier with more prematurity and low birth weight. So timely prenatal diagnosis, it plays a critical role in enabling coordinated perinatal outcome and providing prenatal counseling and diagnosis. And this includes delivering at a specialized center and also availability of other specialties. So this planned approach helps prevent severe postnatal complications such as electrolyte imbalances. In terms of management and prognosis, studies have shown no differences in the surgical management of patients with or without trisomy 21, meaning to say just because you have a client with trisomy 21, you say we don't offer surgery. So surgery still has to be offered, but of course knowing the potential outcomes that may come just because we have chromosomal abnormalities. So, however, there is need for planned postnatal management strategies, which should be important. For example, if an MDT had been done for this patient, if they had come in earlier, that addresses all facets of the patient's conditions. So this includes timing of surgical intervention, which typically should occur within 24 to 48 hours after birth. And in those with congenital malformations, a multidisciplinary team is required. And postnatal parental psychosocial support is also very important, as this woman did seem very traumatized after undergoing amnio reduction, eventually just going into preterm labor and the baby demising. So in conclusion, prenatal diagnosis of congenital anomalies with thorough screening of associated syndromes is pivotal in providing quick and comprehensive postnatal care. Thank you.
All right, thank you. Not too bad, not too bad. 11 minutes, 1 second and 33 milliseconds. Not too bad. All right, so question time. We have 3 presentations: complex pathology, Doppler changes in aneuploid case series by Dr. T. Liayo, gastroschisis by Dr. A. Kwaoga, and duodenal atresia with underlying chromosome abnormalities. Can you shoot them? or you were closed? All right. We're going to give you a prize for asking questions.
Is there any difference in managing exomphalos, omphalocele, and gastroschisis? And what are the subtle sonar differences?
So, to the presenter for gastroschisis, you heard the question? You did. All right. So, all right.
Thank you for the question. So I think the difference between the management of omphalocele and gastroschisis begins even in the antenatal period, because with omphalocele, the risk of chromosomal abnormalities approaches about 50% compared to isolated gastroschisis, which does not have that high risk of associated chromosomal abnormalities. So for patients with omphalocele, these ones would get genetic testing and they would go through a more thorough evaluation of their anatomy to rule out other associated anomalies. And then for delivery, the method for delivery for both of these cases is C-section, is vaginal delivery, unless there are other associated obstetric indications for C-section. And then after delivery, for omphalocele, the reduction tends to be simpler compared to gastroschisis. I noted that with the larger gastroschisis, they normally undergo stepwise reduction of the gastroschisis. Yeah, I hope I've answered you well.
Are you happy with the answer? Doku, do you want to add something?
Just said, but I think Dr. Waoga did well to answer that question. But maybe the only important information we need to know is that she has mentioned that exomphalos is associated with chromosome abnormalities in close to 50% of the cases. So from us, the guys who are on the prenatal side, exomphalos is generally poorer outcome because of this association. When the most common association is Edwards, trisomy 18. So 80% of babies who are diagnosed as having Edwards in first trimester may die in uterus. So that the exomphalos that pediatricians report on are the selected ones, are the good ones. So when the pediatricians report, they normally say the outcome is comparable. But from our side, we begin the journey in uterus, exomphalos is a worse diagnosis. Yeah.
All right. Thank you for the addition. Thank you for the questions, Doc. You can go and grab another plate of lunch for the good questions. All right. Any more questions? I think we are cruising well. We are catching up fast. So we are moving on to the last triple play of our afternoon buffet, academic buffet, whereby we are going to be taken through the journey of Arnold. We are sorry on the typo on the program. It's Arnold. It's not Arnold. Arnold will not be happy with that. So it's Arnold Kiari, 11 case of missed opportunities. Dr. Kwaramba will take us as a 10 minutes start now.
Thank you, Mr. Zanga. Good afternoon, everyone. I'm Faith Kwaramba. So today I'm going to take you through the Arnold Kiari malformation 3, identifying the missed opportunities in the journey of this woman and her pregnancy. So Kiari 3 is the rarest of the Chiari malformations, characterized by high cervical or occipital encephalocele and some osseous defects associated with herniation of the posterior cerebral fossa contents through the foramen magnum. So the incidence is about 1 to 3 cases per 10,000 live births. It's a very rare condition. So of the Chiari malformations from 1 to 4, the type 3 has the worst prognosis than types 1 and 2, and it is characterized by a high mortality rate and severe neurological and developmental deficits in the surviving patients. And it is more common in low resource settings like here in Zimbabwe, where limited access to anomaly screening contributes to delayed diagnosis, inadequate folate supplementation, and poor access to the preconceptional care. So why does this case matter? So unlike Arnold Chiari malformation type 2, Chiari type 3 is defined by the presence of an encephalocele with protrusion of the intracranial contents through a skull defect. So this case demonstrates a classic but advanced presentation of Chiari 3 malformation, which was diagnosed late in pregnancy at 39 weeks plus 6 days, complicated by a giant posterior encephalocele associated with severe ventriculomegaly and suspected associated cardiac abnormalities. And it also highlights multiple missed opportunities for the antenatal diagnosis and prevention. So allow me to present a case of Miss Fmsz, who is an 18-year-old housewife from Chinhoyi. She was in her first pregnancy at an estimated gestational age of 39 weeks plus 6 days. So she came to us at Rare Hospital from Bari, as a referral from Bari Clinic with an ultrasound scan suggestive of fetal defects. So this pregnancy was planned. However, this woman had no preconceptional counseling, and she booked a pregnancy at 12 weeks and had 7 antenatal care visits, and she was HIV negative. However, she had no chronic illnesses and she was not taking any medication. And she stays with her husband in Chinhoyi, who is self-employed, and they are both not on medical aid. She does not smoke or take alcohol. So in terms of investigations, this woman never had aneuploid screening, though she had 7 antenatal care visits. She never had fetal anomaly scan. She was never screened for neural tube defects. No blood tests were done, full blood count, random blood test was not done. And she was never even screened for congenital infections, the torches screen. So the ultrasound scan, which was done at Salim Gabe FMU unit, showed a single intrauterine fetus with an estimated fetal weight of 3,496 grams, and it was a cephalic presentation. However, of note, there was a large encephalocele measuring 130 millimeters with echoes within it suggestive of herniated neural tissue from the posterior fossa, and it was complicated by severe ventriculomegaly. The left ventricle was 39 millimeters, whilst the right ventricle was 34 millimeters, showing ventriculomegaly. Then in the posterior fossa, the cerebellum had herniated into the encephalocele. And of note, the heart was abnormal. However, the abnormalities were not characterized. So these are some of the ultrasound scan images which are showing the ventriculomegaly that I was talking about, and the defect on the posterior fossa. This is also the images which are showing the ventriculomegaly, both the right and the left, and also the defect which was measuring about 2.7 centimeters on the skull, and there was herniation of the posterior fossa contents into the encephalocele. So on delivery, because this patient has presented to us at term, she was scheduled for an elective cesarean section a week later after presentation. However, she went into spontaneous labor and an emergency cesarean section was done. So the birth weight was 2,820 grams, and she had low Apgars of 4 to 5 on 10, and she had a large head circumference which was 41 centimeters. And these are the images showing the baby who was delivered, and she was in mild respiratory distress. That's why she's on oxygen per nasal prongs. And this is the encephalocele which was noted. So in terms of progress, this baby is currently admitted at Salumugabe neonatal unit, and she is now day 59 of life. The ruptured encephalocele was noted to be septic on day 40 of life, and currently she is on broad spectrum antibiotics. However, she is breastfeeding well, and the current weight is now 3,000 grams. And this is the photo of the baby, who is now 50 days of life. So she had a transfrontal ultrasound scan which confirmed the hydrocephalus, and the CT scan brain confirmed the encephalocele with herniated cerebellum tissue. So currently she's awaiting encephalocele repair, which is scheduled for next week on Wednesday. So in terms of preconception, the primary approach to managing the myelomeningocele is prevention. So folic acid supplementation should be started at least 1 month before conception and continued throughout the first trimester, and it helps to prevent the neural tube defects by about 60 to 70%. And it is recommended that women of childbearing age should consume about 0.4 milligrams of folic acid daily. So women with a history of pregnancy affected by a neural tube defect should take at least 4 milligrams of folic acid daily starting 3 months prior to conception, like in our woman when she tries to get pregnant again. So the identified gaps in this case are that this woman did not undergo the first trimester aneuploid screening. She did not have a detailed anomaly scan at 18 to 22 weeks, which could have picked all these defects that were noted. And she was never screened for neural tube defects and had limited laboratory investigations. And a routine second trimester anomaly scan would likely have identified the occipital encephalocele, the ventriculomegaly, as well as the abnormal posterior fossa anatomy. So the role of ultrasound scan in this case is that it can diagnose neural tube defects with 97% sensitivity and 100% specificity, minimizing the need for even invasive tests such as the amniocentesis. And the MRI can further characterize the extent of neural tube herniation, even the brainstem involvement and associated CNS abnormalities. So following diagnosis, management should involve a multidisciplinary counseling, including the maternal fetal medicine specialist, the neonatologist, the neurosurgeon, as the genetic counselors. And given the severe structural abnormalities and poor prognosis in this baby, offering termination of pregnancy was appropriate and ethically justified. So in terms of timing of delivery, the gestational age and the severity is one of the options. You can do vaginal delivery with immediate closure of the encephalocele. You can do even prenatal closure of the encephalocele at around 26 to 27 weeks of gestational age, or you can do cesarean delivery. However, large encephalocele significantly increase the risk of sac rupture, intracranial hemorrhage, and obstructed labor. So in this case, immediate cesarean section after onset of spontaneous labor was appropriate because of the giant encephalocele and risk of traumatic vaginal delivery. So in terms of postnatal management, the management includes airway stabilization, feeding support, the seizure management, and neurosurgical repair and ventriculoperitoneal shunting for the hydrocephalus. And the surgical repair aims to reduce the herniated contents, preserve viable neural tissue, and close the defect and prevent infection. However, surgery does not reverse the existing neurological injury. So in terms of prognosis, it is generally poor and depends on the size of the encephalocele. Poor prognostic indicators in this case include the giant encephalocele, the severe ventriculomegaly and suspected cardiac anomaly, as well as late diagnosis and brain tissue herniation. And the survivors commonly experience neurodevelopmental delay, seizures, cranial nerve dysfunction, and even feeding difficulties. And the low ABGAS in this case suggests significant neonatal compromise. So in this case, the take-home message is that preconception folic acid supplementation, it remains one of the most effective preventive strategies. And routine first trimester screening and the 18 to 22-week anomaly scan are critical for early diagnosis of this condition. And delayed diagnosis limits the reproductive options, the counseling opportunities, as well as the delivery planning. And management requires a multidisciplinary approach involving the fetal medicines specialists, as I have alluded earlier, and other departments. So in low-resource settings, strengthening antenatal ultrasound scan services and referral systems is essential. So this, I would like to thank you for listening.
All right. Yeah, she pressed the stop button on your own. So it stopped on 10 minutes, 26 seconds, and 64 seconds. All right, well done for keeping with the time. All right, so 2 more to go. We are doing well. I think you have to clap hands for me. All right, DJ, I think people are not tired. Probably, I think you've seated for too long. Just stand up and stretch. Yeah, so that there is circulation and you will not have gastroschisis. DJ, are you there or you are sleeping as well?
Baby, calm down, calm down. Boy, this your body, you put in my heart for lockdown, for lockdown, for lockdown. Girl, you sweet like phantom, phantom. If I tell you say I love you, you know baby.
Yeah, stretch. If you don't stretch, I'm going to call you on your own to come and stretch here.
Anyone the ambuzi Mutoya mtaula mkama opi Zina mutoti ngami lami kamufete
Makulayo
Tikani tambo ngizeti bisandu ya upi Ayuwa mcheke.
All right, thank you. All right, more of these are just teasers. More will be coming in the after party. All right, so to be taking us through the penultimate presentation, to be taking us through SLE, heart block complex. Who can guess what SLE is? No, not you. Yes. Erythema. Erytho what? Negative marking minus one. Erytho what? Okay, all right. So to be taking us through that, you tell us more about it. So we've got Dr. Masoka here. Your 9.5 minutes start now.
Thank you. So thank you for the kind introduction. So I'm going to be presenting on systemic lupus erythematosus, congenital heart block complex. But in as much as I have titled this presentation, I just want you to take this as a case of fetal bradycardia antenatally. When you see a patient who comes in with fetal bradycardia antenatally, when it's not because of fetal distress, of course, which you always see in the labor ward, okay. So congenital atrioventricular block affects 1 in 15,000 to 1 in 20,000 live births globally. And it presents, like I've already alluded to, as fetal bradycardia as a result of these various degrees of heart block, which can be first, second, or third. So it may be caused by a variety of conditions, such as autoimmune conditions. We have SLE, we have Sjogren syndrome, structural defects, maybe severe atrioventricular defects or even atrial septal defects. We can also have torches, among others, which can cause carditis and then present with heart block. So the commonest cause globally is actually autoimmune antibodies from SLE, Sjogren syndrome, and other rheumatoid diseases. So this is because in these conditions there is placental transfer of maternal antibodies, which will then cause damage and fibrosis to the fetal conduction system. So this may result in in utero fetal demise, or even after delivery it can cause long-term cardiac morbidity in the newborn or neonatal death. So in this case, I'm going to present a case of congenital fetal heart block, which would then made an impression that it was as a result of SLE. So I'm presenting Miss JC. So she's 31 years old. She was in a third pregnancy, para 1 plus 1, and now gravid at 3. So she came at 31 weeks of gestation. She has been dated by dates. So she came as a referral from a local clinic because they had picked up fetal bradycardia. So there's also the fetal heart. When they did their ultrasound scan, they did an ultrasound scan, it noted a fetal heart that was way below 100, and they also knew that there was a mild polydramnus, and referred to Salem Kabe Hospital FMU clinic. But the mother was otherwise asymptomatic. Patient was specific normal fetal movements. The current pregnancy had been booked at 14 weeks, 2 ANC visits, which were unremarkable. HIV and RPR were negative. She did not have any chronic illnesses, or was she taking any medications that could explain the fetal bradycardia. The social history was unremarkable. So when she came in, what is significant is that she was a well-nourished mother. There was no stigmata of SLE on clinical examination of the mother. But when they tried to listen, midwives tried to listen to the fetal heart, they could not pick up the fetal heart, which can be explained by the fact that when you severe bradycardia, it's very difficult to then separate the fetal heart from the maternal pulse. So they couldn't pick the fetal heart on examination. So the ultrasound scan was then done in the fetal maternal unit, which showed a single intrauterine fetus with a weight of 1,155 grams, and the heart structurally looked normal. That's also an important thing to note in this presentation. But there were some ectopic beats which can happen even in normal pregnancies. And of note is that there was a heart rate of around 75 beats per minute, which confirmed which made the impression of the heart block. There was no pericardial effusion, and there was a mildly elevated peak systolic velocity in the midcerebral artery, which was already discussed in the presentation, could suggest fetal anemia. There were active baby movements. I think everyone in this place is familiar, at least, with this pulse of Doppler of the fetal heart, where we are seeing what I want you to see in this image is how there were very few pulses there. Okay, and the fetal heart rate in this particular image was 75 beats per minute, and you can also see that we do have some ectopic beats. That was one of which seems to also sort of to reset the heartbeat. Then in this image, this is the umbilical artery Doppler. So you can see again very few pulses, and you can see that in the middle there, you can see that the end diastolic volume is going was down, which resulted in raised pulsatility index. And again, I'll just refer to one of the questions that was asked to Dr. Verenga about very low PI. So this case had a high PI, but when you have a pump failure, sometimes you may actually see that they will behave the abnormal low PI that Dr. Verenga was referring to. So what were our differentials in this problem? Could this be autoimmune condition? Was this SLE? Was this Sjogren? Could this be in utero myocarditis, maybe parvovirus, maybe Torches infection, or channelopathies, which could be causing, which can represent as a second degree heart block, or could they be very big? So if in the region of the septum where there is the AV node and where you have the band of Fmsz, if there is a big septal defect there, you can also present with the patient can also present with a fetal bradycardia. So we have to do a series of investigation to rule out our differentials. LGTT was normal, UND, FPC normal. The torches were unremarkable. Okay, then If not, our antibodies were the ones that were had a problem. So the ANA was positive. Then we did anti-RO, which was positive, anti-LA, which was also positive. Unfortunately, the patient didn't have funds for other investigation, which we would have wanted in a patient that you are suspecting SLE. So we didn't have funds for anti-double stranded, anti-Smith, and could also not do the antiphospholipid panel. So what was our clinical impression? Our clinical impression was SLE. Of course, the antibodies can also present typically in Sjogren. They can also be the same pattern, but because we know that heart block in the setting of pregnancy is usually because of SLE, we decided to make a clinical impression of SLE given the financial limitation. So the patient was supposed to be booked for a detailed fetal echo, which confirmed that there were no structural abnormalities and also confirmed the the congenital heart block. Then we counseled the mother about the condition. There was prescribed salbutamol. Patient was also prescribed dexamethasone or tevitrolene, but again she did not have funds for this, so she ended up receiving prednisone, which I'll explain later. So a physician assessment, which is very important, was ordered for the mother to be assessed for any organ damage in the setting of SLE. Then an MDT was planned with the pediatric cardiologist. So the first MDT, there was concern for worsening fetal bradycardia, and the recommendation after the discussion was that we could do expectant management. The FMU patient was supposed to be coming for serial ultrasound scans, then to organize a cesarean section at least by a registrar at term. So the patient had a C-section at term, and a live baby was delivered. Fetal weight was 2,550 grams. APGAR scores was 7, 10, 8, and 10, with a heart rate of 33 to 38 beats per minute. So patient was admitted to neonatal intensive care unit for supportive care. Okay, unfortunately there were no funds for pacemaker insertion. I think I had skipped that during as I was trying to rush. But this patient during the MDT, the decision was that there was nothing that could be done in utero. So the patient was supposed to get a pacemaker soon after delivery. What could only be done in utero was to serially monitor the patient. Okay, then soon after delivery they were supposed to put a pacemaker so that you can boost the heart rate. But unfortunately there were no funds. So day 2 post-delivery, patient started worsening. Another MDT was done. What can we do about this patient? Unfortunately, there were no funds. So the plan was to try to seek alternative other methods to try to obtain the pacemaker, but it would have taken at least a month to get the pacemaker using, other pro bono routes. But unfortunately, the baby deceased 2 weeks post-delivery, awaiting the pacemaker. So if ever you remember anything from my presentation, please remember this slide. So it just shows you that if a patient comes with fetal bradycardia, okay, heart rate below 110, what is the general approach? Okay, so first of all, this patient has to be referred to a fetal FMU clinic. Why? Because they have to sort of make a diagnosis of what's causing that bradycardia. Is the heart structure normal? And if you cannot carry out a proper ultrasound scan to determine the normal or the anatomy of that heart child, then it means that you can't probably diagnose the heart block. What is causing it? Because if you know what's causing it, then you can then plan who is going to manage this patient post-delivery, or are there anything that can be done once the patient is in utero. Okay, so during a fetal echo, that's when the heart block can be towards structurally abnormal. Then probably that's where you then see the severe septal defect that I was talking about, etc. Then if the heart is structurally normal, that's when you need to now rule out other causes like the autoimmune, or maybe the cause of myocarditis like the torches, etc. Okay, so you can then do maternal serology testing, anti-RO, anti-LA. If they are normal, okay, we are considering the torches, etc. So remember this flow diagram. Okay, in our case, we made an impression of SLE congenital heart block, which is due to placenta transfer of anti-RO and anti-LA antibodies. So what do? They damage the AV node and surrounding tissue, causing fibrosis in that area. And the challenge is that often the fibrosis will cause an irreversible third-degree heart block. So most of the times, those steroids, etc. that can be given will not be able to reverse the heart block. But because of concern that the low pulse rate, The pump failure may cause hydrops or even intrauterine fetal death. People have explored salbutamol, etc., and they may improve. Though, to be honest, there is still debate on the best treatment method. And the best treatment method for an approach for the patient can only be discussed through a multidisciplinary meeting. Okay. So, in conclusion, congenital heart block is an uncommon but a serious complication which we can encounter in our setup. A clear approach should be followed for proper diagnosis and treatment. Early multidisciplinary management may improve outcomes for both the mother and the fetus, more so in the absence of financial limitations. In SLE, when there is heart block, it is often irreversible and results in significant neonatal morbidity and mortality unless a cardiac pacemaker is inserted postnatally. I thank you.
Awesome. 11 minutes, 39 seconds and 43 milliseconds. All right, well done. One more to go. One more to go. This meeting is being streamed live on our YouTube channel, Fetal Medicine Foundation Zimbabwe. Also on our Twitter handle, Fetal Medicine Foundation Zimbabwe. Also on, what's the other one? Instagram. Instagram, Fetal Medicine Foundation. All right, so one more presentation to go. How many minutes do you want? It needs just 5 minutes. So our last but not least presentation will be taking us through fetal cardiac pathology, a case of arrhythmias in pregnancy. I think the Mrs. Gayo took us through the fetal heart, how it is properly done. So for you to get these things, you should be able to do the anomaly well. And something probably which he didn't mention because he didn't have time, for you to have properly done a proper anomaly scan, you should have probably about 80 images you would have saved. Yeah, so probably you might need to be refunding your patients. Because 10 images, you will not be able to get these things, but you should have done, for you to get what he took us through, you should have that amount of number of images. So can we put our hands together as we celebrate our last presenter? You haven't seen anything yet. The last is always reserved for the best. So we're going to give him, I think, 30 minutes.
Yeah, okay. Thank you, Mr. Zanga. Good afternoon, everyone. Or rather, should I say good evening? Yeah. So my name is Dr. Mvundura. I'll be presenting a case of fetal tachyarrhythmia. So I'm presenting a case of Mrs. L.R., 21-year-old housewife from Glenview, who was para 2 gravida 3 and EGA 29+1/40 at the time of presentation. So she came in as a referral from Glenview Polyclinic with an ultrasound scan obstetrics showing a fetal tachycardia of 224 beats per minute, an amniotic fluid index of 45 centimeters, which has a polyhydramnios, fetal scalp edema, and a pleural effusion of 19 millimeters. The pregnancy was unplanned. It was due to failed contraception. She was on COCs, but she was not taking them regularly. And she did a urine pregnancy test after 3 months of amenorrhea. However, prior to doing the pregnancy test, she had developed nausea and vomiting, and she was treated as gastroesophageal reflux. So she was put on paracetamol and other drugs she couldn't recall. She booked late. At 27+5 weeks, they did an HIV test. The patient had the past obstetric history of eclampsia in a second pregnancy, which was diagnosed postpartum. She had two children, two girls, both delivered by NVD term, and they were alive and well. She has a positive family history of hypertension, no family history of cardiac disease or sudden death. She was not on any chronic medication, iron supplements. She was not put on low dose aspirin or calcium because of the late booking. The patient is in her second marriage, and she lives with her husband and two children. Her firstborn, who is now 5, was from her first marriage, and her secondborn is the first child with her current husband. She does not smoke, take alcohol, or do any use any recreational drugs. So on examination, the temperature was 36.5 with a blood pressure of 104/65. A general examination was normal. And on the obstetric examination, the height of fundus was 31 centimeters, in keeping with the gestational age. Presentation was cephalic. Fetal heart rate was 220 beats per minute. So these were the ultrasound scan findings when she was scanned at the specialist clinic. Presentation was cephalic. Tachycardia of 244 beats per minute. Left-sided pleural effusion was also noted. Skinny edema. Polyhydramnios with the deepest pool of 11.9 centimeters. Of note, the ductus venosus A wave was absent, and it had high PI, but the rest of the Dopplers were normal. There were no obvious structural defects or markers of chromosomal abnormalities. The heart structure appeared essentially normal. So a diagnosis of supraventricular tachycardia was made. So here is the scan showing a fetal heart rate of 243 beats per minute. And on this scan, we can see that it was the atrioventricular ratio was 1:1. We are having an atrial contraction, which is followed up by a ventricular contraction. On this picture here, we see the pleural effusion. And on the following picture, that's the polyhydramnios. Here is the deepest pool of 11.94 centimeters. This is just the same picture. So as for the management, the patient was then put on flecainide, 100 milligrams POTDS, and the plan was to review 5 days for fetal heart rate monitoring. And a recommended delivery plan was by cesarean section. On the review scan, 5 days later, the fetal heart rate had improved. From 244, it had improved to 132 beats per minute to 137 beats per minute. The left pleural effusion, skinny edema, polyhydramnios persisted. However, the ductus venosus A wave was now present, but it was reduced. The PI remained elevated, and the rest of the Dopplers were normal. So this is the fetal heart rate on the review scan, showing 137, a rate of 137 beats per minute. She was scheduled for review the following week. However, she went into preterm labor, which she described as which started as a rupture of membranes, which was followed up by uterine contractions an hour later, and she rushed to the hospital. About an hour after arriving at the hospital, she delivered, and that was described as precipitate labor. The birth weight was 1,755. ABGA score was 210 to 210. And unfortunately, the baby demised within hours. So I'm now going to my discussion. Abnormalities in fetal heart rate and rhythm occur in about 1% of pregnancies. 10% of the arrhythmias are associated with potential morbidity and mortality, while the rest are benign. Estimated prevalence of fetal tachycardia is 1 in 100 to 200 pregnancies. However, locally, in a cohort of 2,700 scanned pregnant women, only 0.1% had arrhythmias. So this may point to us underdiagnosing fetal heart rate, fetal arrhythmias. So I'll just go through classification of fetal arrhythmias. We can have bradyarrhythmias. The previous speaker presented on a case of bradyarrhythmia, which can be classified into sinus bradycardia, a blocked atrial bigeminy, atrioventricular block, and then the fetal tachycardias, we have sinus tachycardia. These ones are the ones that we usually diagnose, where we have maternal and fetal causes, with maternal causes being maternal fever, endocrine disorders like hypothyroidism, maternal hypotension, and also fetal causes like fetal distress, severe prematurity, and also fetal activity. We also have supraventricular tachycardias. These originate in the atria, and this can be classified into short VA supraventricular tachycardias and long ventricular atrial interval supraventricular tachycardias and atrial flutter. We also have ventricular tachycardias, but these ones, they are very rare in fetuses. So I'll zoom in on short VA supraventricular tachycardias. This is the most common type, constituting 60% of all cases of supraventricular tachycardias. It typically starts with a premature atrial contraction that conducts through an AV node with a retrograde conduction through an accessory electrical connection, initiating a re-entry circuit. So in a normal heart, we have the cardiac, the heart skeleton, the fibrous skeleton acting as an insulation to prevent a re-entry of electrical activity back to the atria. But in this case, we have an accessory conduction pathway. The heart rates usually range from 180 to 300 beats per minute, and AV conduction is 1:1 with a short AV interval. They can be intermittent or sustained. If they are sustained, that is, they are present in over 50% of the time. So here's just a picture showing the accessory pathways. We can have an orthodromic, where the anterograde conduction is through the AV node, or antidromic, where the retrograde conduction is through the AV node. So here's an algorithm showing management of supraventricular tachycardias and atrial flutter. So in cases with no eye drops, flecainide is the first line treatment option. Then for those with eye drops, flecainide plus digoxin can be used. And if there's no response, we can always add another drug. Then for eye drops, digoxin has got a poor placental transfer, so usually it is combined with another drug. So in general, management of patients with fetal tachycardia, we do fetal heart rate monitoring. If the fetal tachycardia is intermittent, that is present in less than 50% of the time, or if the fetal heart rate is less than 200. And then principles of pharmacological treatment include normalization of fetal heart rate, prevention of heart failure, and increasing duration of gestation to term wherever possible, with the aiming to deliver the babies at 38 weeks of gestation. So just like what the previous speaker was referring to, we also have to screen these patients of the Torches infections, because cytomegalovirus, parvovirus can cause myocarditis, which can then trigger these arrhythmias. We also have to screen them for anti-Ro and anti-La antibodies. So as for the prognosis, eye drops fetalis occurs in half of all fetuses with tachyarrhythmias. Overall rate of fetal demise is 9% in untreated cases. If treated by transplacental drug therapy, rate of rhythm control is achieved in 80 to 90%. And 50% of fetuses with supraventricular tachycardia will develop postnatal SVT. So we have to do a multidisciplinary approach, and so that the pediatricians will take over the management of these fetuses post-delivery. Factors associated with the increased incidence of postnatal SVT include ventricular dysfunction, earlier EGA at delivery, and lack of conversion to sinus rhythm during fetal life. Atrial flutter is associated with good outcomes. It almost never once the infant undergo electrical cardioversion. So I'll end my presentation by these key takeaways. Fetal arrhythmias are being underdiagnosed, and when we do our fetal heart rate measurement, we should do it in the 4-chamber view using a 2mm sampling gate, and applying the gate below the AV valves and close to the interventricular septum, so that we get a good wave that we can analyze. And also when we look at the fetal heart, even either to obstetricians or the person who is managing the patient, we should not only look at the rate, but we should also look at the rhythm and the wave pattern. We can get more information from that. Then we need to refer these patients for fetal echo to fetal medicine, and these fetuses, they do benefit from intervention. That is, we can plan optimum delivery time, or else we can institute in utero treatment. Thank you very much.
Awesome. Record time. He did it in 3 minutes, 37 seconds. He had asked for 5 minutes. All right, so we've come to the end of our presentations. The last triple play. I can entertain some questions. I'm being told that by the organizers that the afternoon tea is ready at your homes. Good. All right. I'll entertain a couple of questions. All right. Our best.
Thank you for the day and for yesterday. I thoroughly enjoyed this workshop and yesterday. I'm sure I'm speaking on behalf of all of us. Yes. Shall we give it a... Thank you. Please come back. Follow-ups. I enjoyed these presentations and yesterday. But it's said that you omitted the resus isoimmunization. Because very often if you go to public antenatal clinics, PILO, UBH, I'm sure, you will find that very little attention is paid to blood grouping. There's no blood groups on the records. And nobody knows whether they are blood group resus positive or negative. And I don't know to what extent is the prevalence of isoimmunization and fetal loss because of this problem. So I don't know, I had hoped that you would get updates on the resus problem and how to manage it. Because very often we read in the textbook and that's it. And I'm lucky to have dealt with some cases in the past, but I've never seen another case for the past 10 years. I don't know, Doc. Maybe you can add on to what I'm saying.
Passing on the baton stick.
He's a senior at UPH.
Okay,
Okay, in terms of screening, indeed, we've that's an area where we need to improve is public service. In terms of seeing patients, we see a number in the private sector. We do those tests and we see them, and we try to manage according to the guidelines. But like what he's rightfully saying, I think we need to do more in terms of our public service, so that we manage to reach out to those women and appropriately manage their pregnancies. Yeah. I support it, right?
All right. So probably just to comment quickly on that, I think in Harare, last year we had 2 cases which were picked, and they actually underwent our first invasive procedures of intrauterine transfusion, which were done by our very own fetal medicine specialists. So we actually had cases and therapy was done successfully, and so probably that wave will be spreading to Emagumeni. Probably Doc, you would want to add something?
Thank you. You are right. I think the scientific team, they've heard you. So that in the next program, the research is always a featuring topic. It's a topical issue for sure, so it will be included. The good thing is we now have our doctors with a lot of experience on talking about it, because last year I think they talked a lot about it. Dr. Msara was leading that. So she presented a lot on research. So the resources are there to talk about research. So thank you.
All right. So it should be there on our fetal medicine. I think always visit our channel. I met someone who challenged me, who said they started doing all the Dopplers based on the videos from the Fetal Medicine Foundation YouTube channel. So the resources are there for you to explore. Yes, so on the channel, last year's, it was on the Congress, right? Yeah, during last year's Congress, annual Congress, there were two presentations, Dr. Msara's and a professor from India. So you can visit and enjoy the presentations. Another question?
Thank you. I wanted to ask, in my understanding for the Doppler assessments of the fetus, we have the uterine, umbilical, ductus venosus, and the middle cerebral. So you will find that we have the umbilical is one, the ductus is one, but we have the uterine, which is the right and the left, and the middle cerebral arteries, which is the right and the left. My question is, assuming in a case whereby you find a uterine artery, the right has the notching and reduced ETV, or there is brain sparing in one of the middle cerebral arteries, but if you do the mean, you might find a value that is within the limits. What then do you do in such cases?
All right, I'll not answer because I'm cheering. So okay. All right, so if you find that, let's say one of the uterine arteries, what we normally do, we are on the cautionary side. So if we see that let's say one uterine is really raised, we base on that the worst case scenario, then we work with that one, which is even if the mean is within the normal range. It's a bit different from the preeclampsia screening, which was mentioned earlier, which takes a lot of other factors, which doesn't just use the uterine arteries. Then when it is showing redistribution in one of the middle cerebral arteries, then there is redistribution, and you correlate it to probably the other. You're not just dealing with it in isolation, to the clinical presentation of the patient. Yeah, Dr. Ngora, want to add something?
Just a point of correction. We have two umbilical arteries. I think he said we have one umbilical artery. So we have two umbilical arteries, and of course one can be raised, the other one can be within the normal range. I think if you are getting one middle cerebral artery which is showing reduced PI, you may need to repeat it over and over again, because reduced PI of the middle cerebral artery is showing that there is the brain sparing effect. So there's no way one side is going to show brain sparing effect and the other one is going to be normal. So I think you may need to repeat it over and over again. Same applies to the uterine arteries. I think you explained, Mr. Zanga explained that it will be showing that there's poor placentation and poor adaptation of the woman to the current pregnancy. So there's no way where we are going to have one and the other one is is normal.
And also technically, for the NCA, if you're able to get one, it's very difficult for you to get the other one. So we usually base on one, probably which you can repeatedly measure, and if it's consistently giving you the same, then probably it's pointing to that there's some brain sparing or some hypoxia, which is probably about to take place. In general. I think you should be right. I think it has to do with the placenta. Usually the placenta, where it attaches more, tends to be better vascularized than the other side. So it's not an abnormal finding. We also come across it.
So to just add and say, those patients should be put under surveillance. You should bring them back for growth monitoring. There was some years back, we did a placenta refresher course, I think 4 or 5 years ago, where we were describing the abnormal placenta, that lateral placentas on their own, that's the ones that normally give you that in the absence of hypertensive disorders on the mother or vascular pathology of the mother. Lateral placentas tend to give you that. But people say babies with the lateral placentas, they should be monitored because they have a higher risk of placenta maldevelopment. So the moment you have a high PI, just monitor those babies. We've also seen it from our monitoring that most of these babies may end up with late onset FGR if you follow them up. If one of the uterine artery is high. This is why we practice this kind of caution. The moment there's an abnormal uterine artery, we want to follow up and check for the evolution of the condition.
All right. A question. All right. There's a question here.
Okay. My question is for Dr. Musana. I wanted to understand why we rushed a baby who was 1.5 kilograms with VSD, and we took the baby to operate on them within a few days of delivery. I'm just wondering if the patient selection was okay for that baby, seeing into that the baby demised just a few hours after the operation. Wasn't it possible for us to do maybe parenteral nutrition, let the baby gain a bit of weight, then operate on them later?
Thank you, Dr. Ndagura, for the question. So in terms of the optimal timing of management for clients with duodenal atresia, you'd want to do the procedure within 24 to 48 hours. However, in terms of relating it to the comorbidities that were there in this patient, and knowing that we had a worse prognosis compared to an isolated case of duodenal atresia, they did delay in terms of them doing the procedure on day 5. Why they then went on to do it at day 5 was because they noted constant vomiting from the unit, regardless of the NGT being in situ. There was a concern for possible aspiration, and then they went on to do the correction. I think if possibly we're also limited in terms of our NICU, in terms of monitoring and maybe availability of the parenteral nutrition. So I think maybe this was a better, faster way out in terms of managing those complications that were now arising. Thank you.
All right. So thank you all. Yeah, you have been splendid participants. Can you put your hands together for yourselves? I didn't see anyone sleeping. There was 100% awake audience. So we started our day in the morning with the pyramid of care, turning the antenatal pyramid of care and pregnancy risk assessment, where the main take-home message was the first trimester is not just measuring the fetus or the embryo, but is to do screening. And I think you learned quite a lot that the first trimester actually is one of the most difficult scans which need a higher level of expertise. We then went through the unemployed screening using the different methods, the combined test, the quadruple test, the cell-free DNA test. Then we went through pregnancy dating, fetal growth assessment, obstetric Dopplers, and clinical application, fetal growth restriction, diagnosis and management. Then we delved into multiple pregnancies, care and complications screening, which was followed by a case of TTTS. Then after that, we had pre-eclampsia screening and prevention, cervical assessment and preterm surveillance screening. Then we also had the anomaly, the fetal defects, the different fetal defects, which are over 200. And we were reminded that if we have not come across one and we've scanned thousands, then probably you are missing some defects. Then we went through the anomaly scanning protocol, where most of you, I saw you shaking your heads about the various images which you need to obtain to have satisfied having properly done an anomaly scan. So an anomaly scan is different from biometry measurement, whereby you just do biometry, then after you finish, then you say no obvious fetal defect seen. All right. After that, we're taken through the, what did you call it? The amygdala hijack. This man was full of big words. We're taken through the scanxiety. So we went through the psychosocial aspect of fetal medicine, of obstetric management. And you can really notice that, the subspecialties, everyone will be in their lane, and there's so much depth in each and every area. And I was really challenged on the therapy, psychosocial aspect. Then we went through the different cases, and to be honest, I was thoroughly impressed by the cases. They were quite stimulating. The complex Doppler changes in unemployed case series, the gastroschisis, the duodenal atresia, Arnold Chiari, was it 2 or 3? 3. Yeah, on the program it was Arnold Chiari 2, so you can add another one there. Then we went through the SLE heart block complex, and finally through the fetal cardiac pathology case of fetal arrhythmias. What a day. All right, so without further ado, I would want to call for the closing remarks. It will be in 2 parts. So first and foremost, I'd like to call the founder of fetal medicine in Zimbabwe, Dr. Claudius Verenga, to give us closing remarks. So he will give us the part A of the closing remarks. Can we put our hands together for him? You can do better than that. All right, thank you.
Thank you, Chair. Splendid. It's a demonstration of art of chairing, right? emceeing. Thank you so much, everyone. Midwives, are you here? Can you show me by raising your hands? Great. So Yeah, we love you so much, midwives. All the midwives, where are you? Where are the midwives in Blawayo? Which ones are from Blawayo here, or from another region, which is not Harare? Just two. This is not good. We love midwives. Embrace the midwives, and I think that's the only thing that's the missing link in these meetings. I'm always fighting with the midwives who work with. Say, we want you to present. I don't know who told the midwives never to present. They always promise me, Dr. Virenga, we're going to come up with a presentation. When the time comes, they don't show up. You wanted to be given the topic. Okay, so I think the scientific committee, you heard what they said. They want to be given the topic. Next time, I want you to present. Because what we want you to do is to teach us your experience. I believe medicine, we learn from each other. We learn the experience that you have while looking after patients, so that we may become wiser. We can never be complete on our own. This is why we need everyone on the deck. So always remember this, that presenting, it's a way of you sharing your experience with us, opening our eyes, making us a little bit wiser. So we want you to do something. And next time, guys, you want midwives, maybe we will tell the scientific committee to make sure that the midwives are registered first. The midwives in Pilo, UBH, Gwanda, Cholocho, they should be registered first because we want them to be here. Because we are not complete without them. So I think you agree with me that the future of obstetrics is being shaped. I think you saw the young obstetricians who were presenting here, and it's being shaped right in front of our eyes. So I want to say to all these young obstetricians, don't look back. The future is yours to take. So do not look back. We want obstetrics to be taken to heights that, because I believe we can do anything. That is my belief. I believe we can give the practice that is given in New York, in London, in Sydney. There's nothing that should stop us from giving that kind of service. And this is what we want to see. So please, what you have learned, don't look back. Don't allow even anyone to stop you, including the older generation, right? You have the speed, outrun them, and don't stop. So do not stop what you are doing and what you are learning. Because personally, I'm also inspired by the work that our registrars have been doing in the unit, their presentations, their grasp of fetal medicine concepts. It's amazing. My second point, to the young doctors in Blawayo, refuse to be left behind. Because, I mean, remember, all of you will be seeing the same patient. We have seen patients who actually transfer cities. Say, I'm in Harare today. Say, can you find me an obstetrician to see me because I'm going to Blawayo? The patient should not appear like they've time traveled. Say, this doctor was doing this to me, now I come here, this doctor does not even know about it. So, please, don't be left behind. The doors are open for you. You may wonder, look, I want to say this very clearly to you in this platform, that the future of our obstetrics has to be shaped even in this city is in your hands. You have to do everything that it takes for you to improve yourself. You have to remove fear, because sometimes fear keeps people from changing. Saying, I'm afraid of this, I'm fearing this. You have to remove fear from within yourself. And you have to do the impossible. Personally, I'm just generally attracted to people who want to do the impossible. And I'm also attracted to young people who want to improve themselves. If I see that there's a potential and you want to improve yourself, we would also do amazing things to make sure you improve yourself.
So we want the same level of understanding of fetal medicine issue that was demonstrated by your compatriots from Harare to be demonstrated by you in the next Congress or refresher course. So what does it mean? It means there is need to learn. There is need to make sacrifices on your behalf. I heard that there is an issue of accommodation. We are going to look into it and come up with a solution that allow accommodation to be so cheap in Harare, so that you come and learn and you come and establish and begin to work and we support each other. Because who suffers at the end of the day? Everyone. It's not just the patients. You may also become a victim of the practice environment. Because either you have a wife or a woman, you become pregnant, something will go wrong with your baby, and you want your baby to be assessed properly. And it's so embarrassing to say, in a sea of your colleagues, you just say, I have to travel to Harare to just get my baby properly assessed. We can't normalize that. It's not normal. So this is the drive which I want to give you, to say, guys, how the future of obstetrics is shaped in this country is in our hands. It's not in the hands of politicians. Don't lie and blame the politicians. It is in our hands to shape the obstetric practice and the level at which we practice obstetrics in this country. It is in our hands. So that's my number 2. Then my number 3, I just want to thank the scientific committee. They've done a splendid job in organizing all this. So I'm super happy with the work that has been done, and the amazing work done by Dr. Mguto, Dr. Lupepe and team, and Dr. Doreen Pilo, mobilizing everyone to come to this meeting. Thank you so much, colleagues, for doing this. And then the 4th thing, I was inspired by the young man, the Pende. He really impresses me. I like the way he does these things. But we don't want him to be alone. I know we have Tafadzwa. Is Tafadzwa still here? She left. Okay. We also have Tafadzwa, who is a clinical psychologist who works with us at Parenyato and also at the clinic. But when fetal medicine is being set up in Blawayo, we also want to include the clinical psychology teams to come for attachments, because people will need therapy. I think he has highlighted more than we can even expect, that it is not right to tell people bad news and leave them to suffer after. So just remember that we also want to support training in fetal medicine work for family therapists and clinical psychologists. So whenever you guys decide that you have somebody who is interested, always remember we want to support that initiative, because we feel it is important to address that gap. Otherwise, people will continue to suffer because of us, because of you when you diagnose them with problems. So we want to try and address that concurrently together with the clinical side. Then we, for the students, for the registrars here, as Fetal Medicine Foundation, we offer support to people who are researching fetal medicine. So if you are researching fetal medicine, get in touch with Thelma. I hope you all have details now. So if you are studying anything to do with fetal medicine, always get in touch with Thelma so that we give you the help that you need. Then for those who successfully complete their research, we will submit their research to the Fetal Medicine Foundation World Congress, which takes place in June. And if your abstract is accepted, then we'll sponsor you to go to the Fetal Medicine World Congress, right? So remember this, that if you want to study in fetal medicine as well, and maybe you don't have data in Blawayo, and you want to study a topic where data is to come from Harare, we are opening the gates for you. So you may consider to do that, just get hold of us and say you have these topics you want to study in fetal medicine. One of the roles of Fetal Medicine Foundation is to promote the development of fetal medicine, or to promote the widespread use of ultrasound. So wherever there's obstetric ultrasound, Wherever there is fetal medicine learning, we are there to promote that. Then number 5, I want to announce a society. We've since now, because the foundation has been spearheaded in the wake of fetal medicine. But now we have organized ourselves into a society, which I want to introduce the leadership, the interim leadership of the society, which you can join. The joining fee has not been set, but I think it's now going to be set and announced so that people just have a small joining fee, become a society member, and benefits from being a member of a society. So I think if you could, guys, if you could just stand up so that people see who is who in the Fetal Medicine Society of Zimbabwe. Yeah, you could stand, guys. So we start right at the end. Mr. Kumbula is our SG, interim SG. Then Dr. Ndaguro, our scientific chairman. Then Dr. Mr. Zanga is a committee member. Dr. Hlachwayo is not here, who is a committee member. She is out of the country. She is our treasurer. And I'm the interim president for now. So we are known as Fetal Medicine Society of Zimbabwe. So that's the society which will be spearheaded in the scientific activities and all other work that are coming, including the Congress. I thought you guys had a poster to show people when the Congress is coming, but I think it's going to be announced through all the forms of groups that there's a Congress. We always hold a Congress. We have a refresher course in first quarter. It's all right, you may see that. First quarter, there's a refresher course. Then in September, October, depending on the scheduling, there's a congress, which will be mainly a scientific discourse. It's a 2-day congress. I think this year we want to make it a 3-day. Because last year 2 days were not enough. Unfortunately, or fortunately, to be in Harare, but we are also planning that maybe future congress will be rotating. But the fetal medicine refreshers, they are moving from to this year we're in Blawayo. Next year, of course, we debate to say where will we be, the Mutare, Mashingo, or Ogweru. The refresher course will be moving around. While the Congress will still see our best to rotate it. Thank you. Thank you so much.
All right. We can do another round of applause. Okay. Another point which I wanted to mention is that all the images you were seeing in all the presentations are from our work. They are not from YouTube or ChatGPT. So all the images are from the work which is being done, the great work which is being done by fetal medicine people, Zimbabwe. All right, so to give us the icing on the cake, I'd like to call upon Dr. Muguta, our hosts. They've been wonderful. Blow has been awesome. I think we are coming back again next week.
Okay. Thank you so much. What a power-packed refresher course that we had. This was amazing. I learned a lot. And you know what? It was after, it was during the ZISO Congress, annual Congress last year, and it was after one of his insightful, inspiring presentation. You know, after Dr. Venga speaks, I mean, you can't not be moved. You just feel like wanting to join fetal medicine. I mean, sexual and reproductive medicine, but I'm thinking. So it was after one of his presentations that we discussed and requested for them to come through to give us a refresher course. I thought it was just a hype kind of discussion. And then after, I think, beginning of this year, that's when they communicated and said they were planning to come. So thank you so much for honoring our invitation, which was so informal. And you came through with such a big team. We really feel honored to have you here. So thank you once again. Can we just give them a round of applause? One thing that I love about them is that they are so tenacious and passionate, and you can't miss that. And I hope it's going to rub on us. Not that I'm saying we are not passionate enough,
but we also want to be doing things. So I hope he's rapping on us, and we're really going to be changing as Southern Region and be taking ownership to do some things here. I want to extend our sincere appreciation to everyone who contributed to this success. Over the past sessions, we have had the opportunity to revisit important principles, explore recent advances, and exchange practical experiences in fetal medicine. The discussions, case reviews, and shared expertise have reinforced the importance of continuous professional development in ensuring the best possible outcomes for both mother and child. Fetal medicine continues to evolve, like what we have seen and what they've all been saying, and keeping pace with new development requires commitment. I mean, if you are to do such, he's saying you need about at least 80 pictures. That's commitment. You can't have 10 if you're doing a good job. So we really need to be committed. We need to be curious to find those things. If you're not curious about it, you will not get it. We need collaboration, working with every other specialty that has been highlighted, including our psychosocial support. This course has demonstrated the value of learning together and strengthening the multidisciplinary partnership that are essential in modern maternal and fetal care. I would especially like to thank our facilitators and presenters for generously sharing their knowledge and experience. And they are also sharing that online as well. So we are not limited to these presentations. We're going to have access online. Your dedication to teaching and mentorship is deeply appreciated. To all the participants, thank you so much for active engagement. Special thanks to Dr. Museta. Is that? Yes, thank you so much. He was quite engaging and he kept on probing. Yeah, thank you so much for that. As we return to our respective institutes, but before I move on, let's take note of the new terms that we have learned. Scan anxiety. Scan anxiety. Yeah, you know, that's, you know, he went on to develop a new term. That's love and passion for his work. So we really appreciate that. As we return, and sonotherapy as well. As we return to our respective institutions and practices, where we carry forward not only the updated knowledge and skills, but also the renewed motivation to provide compassionate, evidence-based, and patient-centered care. As the Southern Region, we hope that we have a number of our cadres going to be trained so that we can also train our own. Can there be somebody who is passionate enough to join fetal medicine and go and be trained? You heard him, they are going to support. So can we have that love for it and take this up so that we are not left behind? I also wish to acknowledge all the organizers who organized this, the support teams who have done such a good and amazing work, and who worked behind the scenes and made this possible in a successful meeting. Just special mention to our mother board, ZESOG, Fetal Medicine Society board, all the facilitators, all you participants, as well as our sponsors. I'm not sure, I can't mention them by name. I didn't get the list, but we really appreciate our sponsors who came through and support this initiative. Cresta Chechu Hotel staff, thank you so much for supporting us, as well as UBH admin and Mpilo admin for supporting with equipment. Thank you to everyone. Safe travels as we return home, and we look forward to meeting you soon, and as we learn and grow together. Okay, so our sponsors, we have got MedCity, KDB, Fetal Medicine Foundation Zimbabwe, and Fetal Clinic. So can we just give it up for them? So on behalf of Southern Region, we really appreciate and we hope you come back and you do another wonderful course. Thank you.
All right. No, you've been amazing hosts and hostesses. All right, we really enjoyed our stay here. Lost and found property. There's a Rolex here. Someone forgot their Rolex. Okay, you can come and see me afterwards. All right, so we've come to the end of the 2-day program. Those who are traveling, may you travel safely. And those who will be traveling tomorrow, may you also travel safely. And probably just to reiterate some gratitude. I think I shouldn't say it. Can you say it when representing your colleagues?
It's difficult to speak after the elders have spoken, but we just wanted to say thank you to the Fetal Medicine Scientific Committee and everyone who was involved for sponsoring us as the students to coming here for accommodation. We're really grateful. Thank you.
All right. Thank you so much for all the sponsors. But I just want to say again what has been said. I think people need to be given their flowers whilst they are still alive. I think what you said, I think you just said the right thing. It's difficult to deny this man. There's nothing which is impossible with him. From the 7 years I've worked with him, there's now, if he says next year we'll be holding the fetal medicine refresher course in Cape Town, you better believe him, because that will happen. So such passion and such dedication, I think it just rubs off on everyone. We really appreciate you. Thank you for the vision. Thank you for introducing fetal medicine to Zimbabwe. I think it has really changed the way our mothers, our sisters, our relatives, our friends are being taken care of. All right, so thank you all. We'll see you next year. Please, Bulawayo. I wanted to say blue. So please, Bulawayo, when it's being hosted probably in Mutare, we want you to be part of the bandwagon. Thank you.
I forgot. Carry me the love, carry your
I see what you do. You put your body through. I like the way you move it, oh. I can feel the vibration of your body moving. You put your body